Hello, everybody. Welcome to the day 2 of the BMSS annual conference. And so it's a great pleasure to be here with every one of you here. And so, yesterday was an excellent program, isn't it? And we look forward to, a very encouraging program today. And so we have a great, wonderful group of panelists as well as speakers, and we really look forward to working along with all you attendees, right? Yeah, so actually I am Ananti Krishnamurthy, and I'm medical doctor from Malaysia, and also a member of the BMSS. And I have together with me a wonderful co-moderator. She is also a dear friend. I first got introduced to, PBM or bloodless medicine through Elora. Yeah. So when I meet Elora and the rest in Sabum, yeah. So here is Elora Top, and so she is a client delivery lead from Acumen USA. So Elora, would you like to say hi to everyone?
Hi, good morning, everyone. Glad to be here.
Great, thanks. Yeah, so later we will work along in this session. And so today's actually day 2, right? So this is the symposium for bloodless medicine education. And so today's program is about getting the experience from speakers from different regions, right? So we actually have 3 speakers, one from Malaysia, one from Spain, and also one from USA. So we'll be, in a sense, looking at Asia, Europe, and America, right? Yeah. And I would like to introduce also the first speaker. Basically, the first topic, right? She's going to present on bloodless medicine education experience from Malaysia. And the speaker is actually Dr. Jameela Sathar, also a very good friend. Yes, and someone that is I think that's an echo. Yeah. All right. So Dr. Jameela Sathar is actually our consultant hematologist, and also she is a former head of service for the hematology service in Malaysia. And she is actually responsible for the care of patients with thalassemia, hemophilia, thrombosis, and bleeding disorder. She has done a lot of work in these areas, and she has been instrumental in developing the National Thalassemia and Hemophilia programs and also guidelines. And this has definitely made a huge impact in the patients in these areas. As well, she is actually leading the patient blood management and also the bloodless medicine work in Malaysia. And she is also the president of the Malaysian Society of Patient Blood Management. So with no further ado, I would like to call upon Dr. Jameela Sathar to actually present her talk. Thank you.
Thank you. Thank you, Nancy, for the kind introduction. I have to put my headphones on because suddenly the neighbors' dogs are barking and the cats are fighting outside. So I'd like to thank also the Dr. Nathaniel and his team from BMSS in inviting me to talk to you about our experience from Malaysia on bloodless medicine education. I'd like to share my screen. Okay. Can you all see my screen? Yep. Firstly, I would like to say that as clinicians, it is our duty not only to treat our patients with utmost care, but we are also, our duty is also to educate our trainee specialists as well as patients, so that with education, we would all work together to improve patient outcomes. What I'll do is I'll begin with touching on a brief history of bloodless medicine and surgery in Malaysia. This go back to more than 30 years ago. It started in 1994 the first bloodless triple coronary bypass heart surgery by our cardiothoracic surgeon, Dr. Yahya, and our anesthetist, Dr. Katiresen. And this was followed by a bloodless limb amputation by Dr. Charles David in 2004, a bloodless scoliosis correction surgery by Dr. Ahmad Hatta. And here is where he used the cell saver. And in 2007, bloodless aortic valve surgery by our cardiothoracic surgeon, Dr. Pao, who optimized patient preoperatively and used meticulous surgical skills as well as techniques to reduce intraoperative blood loss. What all these surgeries had in common was they were all performed on patients who were Jehovah's Witnesses. Yeah. However, this approach was not offered to patients who were not Jehovah's Witnesses. And in 2012, we were seeing a lot of unnecessary blood transfusions in our hospitals. Surgeons were topping up patients with blood transfusion to bring up hemoglobin above 10 prior to surgery, and also in patients who are medically ill. So Dr. Asral, our hematopathologist and team, we started off the transfusion safety workshops. And here she is on, this is Dr. Asral. She's preparing fake blood for the workshops. And this is one of the workshops, one of the sessions showing you a patient receiving blood transfusion for epistaxis. Yeah, and this is to educate doctors not to transfuse blood inappropriately. And in the same year, the first patient blood management symposium was held, and that was led by Dr. Ananti and Dr. Pao and team in collaboration with National Heart Center, National Blood Center, and with Suydam. And I was not aware of PBM at that time, but and this is a picture to show you the first PBM symposium, and I think you all recognize Prof. Dr. Pao. I think that's James Reynolds and Dr. Lee. And in 2013, I was introduced to patient blood management by the Jehovah's Witness Hospital Liaison Committee, who was headed by Mr. Stephen Seaver. Yes, he actually was giving a talk in the university where my husband was working, and so my husband asked him to approach me in Hospital Ampang. So here he is, Mr. Stephen Seaver, in one of our workshops. So I invited him over to our transfusion safety workshops, and he actually showed us a video on Dr. Dental Cooley and we were all hooked. Yep, we were all hooked on this new approach of patient blood management. So in 2014, we transformed our transfusion safety workshops to patient blood management workshops with our team of enthusiastic clinicians and even nurses. Yep, we developed our own local PBM modules. There were 7 modules, and here are pictures on the side here showing a station showing how the cell saver is used, and also over here how why we should not transfuse blood to our patients, and we talk about all the dangers of blood transfusion. So we have these workshops every 2 to 3 monthly. We invite participants from each hospital, and they all have to send a team from each discipline, nurses, doctors, blood bank staff. And we had it regularly right up to 2019, end of 2019. And we actually managed to educate all hospitals throughout Malaysia on patient blood management. In 2015, Dr. Carol Lim, she came to one of our workshop, and she was so inspired that she went on to do workshops focused on obstetrics, because she's an obstetrician nationwide. And here are some pictures to show you how we carry on our workshops. So our workshops is the first day is education, is talks, and then the second day we have hands-on workstations, as you can see in the picture here. Also in the same year, through our connections with Dr. Ananti. I met Dr. Ananti also in 2014, and she was instrumental in connecting with other societies. And so we then joined ASPBM, which was formed in 2015. And in 2017, we co-hosted the third ASPBM symposium. And as you can see here, I think you can recognize some of the face here. There's Prof. Shender at the back here, Reynolds, Prof. Al, Kim here, Lee, Dr. Pao is here, and this is Dr. Carol. And in 2019, together with clinicians who are passionate on patient blood management, we officially formed our society. And this is our logo here, showing you a patient, and the 3 pillars of patient blood management. And this is a drop of the patient's own blood and how we could optimize the patient such that they have improved patient outcomes. Dr. Anti was the honorary secretary, and I am the president of the Malaysian Society of Patient Blood Management. And we work hard to develop our PBM guidelines. And here are some of our guidelines. And we also wrote a 28-page proposal on implementation of PBM in hospitals throughout Malaysia to the Ministry of Health. Then come 2020, that, as you all know, it's COVID-19 pandemic. We moved our education, bloodless medicine education, to online, to virtual. And I'm just going to show you what we have carried out. This is a webinar to the public. We talked about, we had a theme called Love Your Blood, and we talked about what is my hemoglobin, what is iron deficiency, and what are my rights. This is for the public. And here are all the participants. We had a good turnout, about 200 people attended our workshop, and we had many questions, and it was actually very wonderful. And also we had webinars to healthcare providers where we talked about perioperative patient blood management. And we also invited international speakers. You can see here, Dr. Nathaniel is here, Dr. Lara. And we talked about preoperative, intraoperative, and we've yet to do the post-operative patient blood management. We also went on to develop pamphlets, patient education pamphlets on anemia and patient blood management. This is in English, and we have also come up with the Malay version, and I hope probably we will also come up with the Mandarin version. These are education pamphlets for healthcare providers on perioperative patient blood management. And we came up with posters as well, and we plan to print all these pamphlets and posters, and once we get all these versions sorted out, and send it to all hospitals throughout Malaysia. And in August 2021, we had a virtual meeting for the Malaysian Society of Haematology, and we participated with a virtual booth. And we had a lot of clinicians asking about patient blood management. And I talked on saving dollars with cents, mainly, particularly how we can save, save by not transfusing blood inappropriately. And we also came out in the news. This is the journey of patient blood management, an article written by Dr. Ananti. This journal is read by doctors throughout Malaysia. And we also went live on TV and on air. And here you can see Prof. Shander and Frosler talking during the first live airing of patient blood management. And then that led to more talks on patient blood management by our team. And I was talking here in Malay, in a Malay TV show. And this is Dr. Mandy. she's talking in Mandarin. And again, here's Dr. Ananti. So we got a lot of calls from public wanting to know about patient blood management. So we reached out to a lot of people, to the public. We also had several grants from stakeholders, and we actually went on to got a professional company to help us do educational videos. So we made 5 educational videos. All this can be seen on YouTube, and we also have it on our website. What is patient blood management? The dangers of blood transfusion, on a video on perioperative patient blood management, iron deficiency and iron deficiency anemia, and iron deficiency anemia in children and pregnant women. So I ask all of you to go to our website, www.pbmschuur.com, and all these videos and pamphlets can be downloadable from our website. And we also had a Facebook Live public forum just recently in July 2022. And also we could target a lot of audience out there wanting to know about patient blood management. And we actually talked about precious blood of mine, also PBM. And this can also be seen on our website. We've also invited ourselves to talk on patient blood management to specialist trainees and medical students in various universities. And Dr. Ananti had come up with a CME module in patient blood management, and you can get CPD points on the MEMS website. And lastly, we had actually collaborated with MEMS and with the Ministry of Health to come up with the iron deficiency clinical practice guidelines. And this will be starting off very soon. And we hope to develop and finish this guideline by 2024. We also did a survey in 2017 to see the response from clinicians about their knowledge on patient blood management. We had more than 1,000 participants who answered the survey, and we asked them, one of the questions we asked them was, I would allow my patient to undergo a major elective surgery with hemoglobin of 10. 82% said they would allow, and so, we started our patient blood management education since 2014, and we still, have a long way to go. And in 2021, we again asked the question in a different format. But we asked the question, anemia is a contraindication to elective surgery, and we have 41% saying true, it is a contraindication to surgery. So we have improved by 40%, and hopefully we can improve that further. So this is the proposal that we presented to the Ministry of Health on implementing patient blood management in hospitals across Malaysia. And we asked the Ministry of Health to form a committee and to make PBM a standard and requirement for all hospitals. So we had this call to action to the Ministry of Health. They took it very well, but however, this was presented in 2019, COVID pandemic came about, and so all this was stalled. So in early this year, I revisited PBM to the Ministry of Health, and in March 2022, they formed the National PBM Committee, and they had their first National PBM Consensus meeting in 16 to the 18 August to come up with a module on patient blood management. So we started off, very, very slow, snail pace, from 1994 to 2019. We were seeing some progress, but not much. But I hope with the formation of the National PBM Committee, we hope to see a giant leap forward. And I hope by 2024, we would have the PBM consensus up and running, the iron deficiency clinical practice guideline completed, and I hope by then the Ministry of Health would direct all hospitals and clinics to implement patient blood management. I also hope to see more bloodless surgeries in non-Jehovah's Witness patients, the use of IV iron and erythropoietin use, data collection. We should collect our data, and we should have more PBM audits. And by having data, we will then have more clinical research looking at patient outcomes and a reduction of transfusions and its cost savings. And I hope by 2030, we'll have PBM practice in all hospitals throughout Malaysia. I think that could be a reality if we all work together, and continue with bloodless medicine education and not to stop, So there are many challenges. There's a lack of awareness among our healthcare providers, our patients as well. Current practice is deeply ingrained. It's quite difficult to change, but we will persevere. There's lack of champions, lack of interactions and communications within one another, between disciplines, and of course, lack of data. So to overcome these challenges, we need to increase our awareness on PBM. We need to have this bloodless medicine education continuously. We need to work together. Everyone can be a champion. And we hope that the Ministry of Health would direct all hospitals to implement PBM throughout the hospitals and to do audits. And we need to have a registry to collect data. And with that, I end my presentation. Thank you very much. I'll be happy to answer questions at the end of my talk.
Thank you, Dr. Jameela. That was just a beautiful presentation. I'm sure everyone has a lot of questions. So please, everyone, remember to put your questions in the chat for Dr. Jameela, and then we'll ask those questions at the end of all of the presentations for this section. It's my pleasure this morning to introduce Professor Xavier Soler. Dr. Soler received his degree in medicine and surgery from the University of Barcelona in 1980. He did his fellowship in intensive care medicine at Hospital Vall d'Hebron from 1980 to 1985. He received his PhD in medicine and surgery, summa cum laude, in 1995. Dr. Soler was a consultant in intensive care medicine at Hospital Vall d'Hebron 1985 to 1990 and Hospital Universitari Hermans Trias y Pujol 1990 to 1995. He has been the director of the ICU at Teknon Medical Center from 2009 to present and director of Bloodless Medicine and Surgery Unit from 2010 until today. Dr. Soler is a member of the European Society of Intensive Care and medical director of Masters in Transfusion Medicine, Universitat Politècnica de Barcelona. Dr. Soler is also on the board of the Maturity Assessment Blood Management Project. Dr. Soler will be presenting bloodless medicine education experience from Spain. Dr. Soler.
Hi. First of all, I would like to express my gratitude to the organization and especially to Dr. Ozawa for his kind invitation to participate in this event. I'm very excited about these initiatives. I know perfectly the effort that's mine. Okay, start with the presentation. Wait a minute. Sorry. Sorry. I'm sorry. Okay.
Do you see the share screen?
I'm trying. Sorry.
The share screen at the bottom. No, not working.
I apologize.
That's okay.
Okay, doctor. Yes, let me share screen.
Sorry. Okay.
Dr. Sola would like to use his own slides, then maybe we have to stop this other screen share.
Okay. I think Dr. Jameela is with the screen open also.
Okay, Naoki, could you take off this one so that he can?
Okay, I try.
Okay, try again.
Okay, I repeat. I try. For that.
So if you're unable to, then Naoki will screen your slides and advance them for you.
Ah. Okay, at least. Okay. Can you see now?
Yes.
Can you see my presentation? Okay. Apologize.
You need to put it on exactly. Go to slideshow.
Okay. Perfect. Now, can you see my presentation now?
It's perfect now. Thank you.
Perfect. Apologize. Okay. Well, when I finished my formation in the medicine university around 1980s, there are only isolated initiatives that began to emerge to provide medical and special surgery care to patients of Jehovah Witnesses religion denomination. These kind of initiatives were only individual, are absolutely lonely, based on the voluntarism of some people and without absolutely any support from the public administration or the hospital management. Often all these initiatives were misleading and deceitful. On those years, there are a very paternalistical vision of the medicine, and there are not important trust attached to the principle of the patient voluntarity. The situation of being confronted with a patient who expressed his refusal to administer blood product will produce a generated universal rejection until all the professionals of medicine. And the most common response of the professionals of medicine was to consult a judge. And the consultation to the judge was waiting to release the responsibility from the doctor and the hope that the judge will violate the principle of the patient of the autonomy and authorize the administration of blood products to the patient. The situation was aroused even in the case of minor surgical procedure, and the invocation of the section of the principle of autonomy was seen by the medical profession as a provocation to his authority and the performance of his work. That was accompanied by very little or known knowledge of the part of the doctors and surgeons of the utilization of the blood products. Because if you examine exactly what's the formation of all the physicians, we must know that here in Spain, the university training during 6 years. During 6 years, in the curriculum in the university, there are only 2 hours of the specific training in transfusing medicine. 1 hour is devoted to ABO typing, another hour is devoted to microbiological safety of the plasma derivatives. Doctors in his fellow formation were training in the use of the blood derivatives only by the experience of his colleagues, of his tutors. And those people that have very few formation of medical transfusion. Unfortunately, at the present time, the situation has not changed. In my opinion, it's very essential to incorporate transfusional medicine as a subject in the curriculum on the University of Medicine. because what's happened with the other patients that are not Jehovah's Witnesses? The physicians see the blood products were obviously perceived by as safe, effective, free of side effects, life-saving, and indispensable in routine medical practice. The transfusion level of 10-20 was mandatory, and plasma was widely used to correct coagulation, as a blood volume expander, as a supply of coagulation factor during intraoperative surgery, and etc. The situation, unfortunately, did not change in the decades that followed when these individual initiatives came and when becoming not consolidated at time. What are the first steps in PBM? In 2005, the Anemia Working Group Spain was created at the initiative of some professionals, including Dr. Muñoz from Malaga, Dr. Abisbe from Barcelona, Dr. Quintana from Madrid, Dr. Pereira from Barcelona. OG was born as a multidisciplinary group from the study of the anemia related to the patient, with the participation of the anesthesiologist, hematologist, intensivist, and biochemist. His main objective is to study the physiopathology and the anemia associated with the surgical patients. The evaluation of clinical laboratory parameters useful in the definition and diagnostic of the different types of anemia present in the pre- and postoperative period. The analysis of the clinical repercussion, quality of life, and socioeconomic impact of postoperative anemia. The study of different therapeutic approaches with emphasis of their cost effectiveness and their capacity to reduce allogenic transfusion. This group vocation is not only research, but also training and consultancy. His training project includes an annual congress, the development of treatment protocols for preoperative anemia, intraoperative and postoperative blood salvage, and the treatment of postoperative anemia. At the same time, an online training program was developed to data treatment of anemia and transfusion medicine. What's the position of the scientific societies? The Spanish Society of Intensive Care Medicine created the Working Group of Blood Products and Transfusion in 2003. It currently actually has 17 active members. The aim of the group is the dissemination of knowledge and the promotion of the research and training in areas of interest, that is, hematologic disorders, processes associated with hemorrhage and thrombosis, treatment of these disorders and processes, massive hemorrhage and massive transfusion, and patient blood management programs. They make a lot of research. Actually, there are the program of Annexus to determine the impact of routine blood extraction, the PlayCrit, that is a program to recording the use of platelets in critical patients. Also, they make the program of training. They will redact a book, Coagulopathy in the Critical Patient. They make the casting courses, is a patient of blood management and casting workshop. And the MRCP courses devoted to the coagulopathy in patients with massive and critical hemorrhage. They write a lot of documents, as the document of preoperative operative management of antithrombotic measures, the update of the civil document, that's the PBM program devoted in critical care, and document in the anemia in critical ill patients. The Spanish Society of Anesthesiology created in 2010 the section of hemostasis, transfusion, and fluid therapy, and in 2021 was created the working group in patient blood management. Here in Centro Médico Teknon, in 2010, we presented to the management of the hospital a program devoted to providing medical and surgical care in all specialties, covering both minor and complex surgery to patients of the Jehovah's Witnesses confession. This project included the voluntary incorporation of a specialist of recognized prestige and extensive professional experience in all medical and surgical specialties. the drafting by legal department or relevant documents concerning informed consent and transfusion refusal, and development of protocol for the detection and treatment of preoperative anemia, the reduction of the preoperative bleeding, and the improvement of tolerance to postoperative anemia following the three-pillar PBM model implemented in ISA-BM. In addition, a follow-up to the CBM, we developed a patient blood management awareness week project for all hospital staff and patients. During this week, lecturers explaining the PBM concept were organized. The leading specialists from Europe and the USA were invited to participate. The awareness week was held annually in between 2011 and 2019, until we were convinced that its concept has become sufficiently well established among the medical and nursing staff of the center. At the same time, the 2-year online master in transfusion medicine was developed, of which 3 editions have been held so far with a great success in the terms of enrollment. Here you can see some of the programs that made of blood management in different years. Finally, we developed the maturity assessment model in PBM. This was designed in 2014 with the aim to helping hospitals to adapt their clinical practice to reduce unnecessary or avoidable transfusion and thus improve health outcomes to the patient. The MPBM objectives that was created here in Barcelona with the help of Dr. Abisbe, Dr. Corominas, Dr. Abasora, and myself, were identify transfusion variability by procedure, assess the maturity of existing clinical practices to avoid overtransfusion, facilitate the implementation of the different components of a PBM program, continually evaluate the outcomes of clinical and transfusion process and the clinical evolution of patients, monitor the degree of implementation and extension of its PBM programs, benchmarking with other hospitals, facilitating the communication between medical teams and management in the implementation of PBM and monitoring the results. The analysis model is based on the maturity matrix that included organization, is a structural model in organization, training, and information systems, processes based on the TPPM, 3 pillars of the PBM, applied in 7 surgical procedures with high consumption of blood derivatives, transfusion index adjusted by casualty and comorbidities, and the outcomes, mortality, length of stay, complication, 30 days of readmission. The maturity of every hospital is classified in 4 stages: basic, initial, advanced, and excellent. These were the indicators that we use to evaluate the maturity of every hospital. That's including the percentage of patients with perioperative visit, the percentage of patients with iron metabolism and inflammation parameter requested, the percentage of patients with perioperative anemia treated, the percentage of patients with ferritin deficiency with or without anemia treated, and etc. And that was applied to 7 procedures: total hip replacement, total knee replacement, cardiac valve surgery, open colon neoplasia surgery, laparoscopic colon neoplasia surgery, and gastrointestinal bleeding and femur fracture. At the start, in 2015, there are only 9 hospitals included in the program. Then in the next year, we arrived to 21. Next year, we arrived to 35 hospitals. Next, in 51 hospitals. The next one in 54 hospitals. In 2020, 64 hospitals. In 2021, 76 hospitals in all the space, in every province of the space were included in the MPBM program. And what can we see? That's that we show the transfusion rate in 2017. In 2017, as you can see, there are a lot of dispersion of the transfusion rate for hip replacement, for hip and knee replacement, for neoplasia of rectum and colon, for laparoscopic surgery of rectum and colon, for the hair surgery of valvular disease and the femur fracture, and for the digestive hemorrhage, for gastrointestinal bleeding. In this important number, near to 45,000 patients, we can see that there are a very high dispersion and very high number of transfusion rate for each process. You can see in the cardiac surgery, there are some hospitals that derive 90% of the transfusion rate for the heart valvular replacement. In 2021, we can see that there are a very important reduction of the transfusion rate in all the processes, and the less dispersion of the rate of transfusion between the hospitals. If you can see some dispersion more important in some hospitals, where probably devoted that's the hospitals that are included for the first time. That's a big show that the formation in the hospitals, they included in a very serious program of the control of the transfusion rate and the good use of the blood products, that results in the very important decrease in his blood products. When we study the structural matrix of maturity, that it's, as I explained previously, it's divided by organization, formation, and systems of information with a questionnaire in every aspect, then they made an average of every hospital, and we divided in four levels. Basic, when the hospitals arrive and less than 25% of compliance, intermediate between 25 and 50%, advanced is 50% to 75%, and excellent that it's a compliance of more than 75%. We can see, and in 2016, there are one hospital that's arrived only at a basic level, and the most part of the hospitals are in the initial level, and someone in the advanced level, but anyone arrives to excellence. What happened in 2021? As you can see, there are any one hospital that is in the basic level. The number of the intermediate level is increased. The number of the advanced level is very well increased, and a lot of hospitals have arrived to the level of excellence. In numbers, we can see that in 2021, 22% are placed in the intermediate level, 46% arrived to advanced level, and 21% of the hospital, they arrived now to the excellence. What is our experience in the influence of the program of patient blood management? Here you can see the evolution of blood product consumption, explained not by us, by the Bank de Sang of the sheets, that it's the state organization that's provide the blood products to all the hospitals in Spain. In 2010, we consumed 3,800 units of blood and 3,165 units of plasma. In the next year, to start a program of PBM, we reduced the number of the unit of blood to 2,416. The explanation of this important reduction is based on the put and severe order to transfuse the unit one by one. Only by this measure we accomplished this important reduction. Then in the time we have a very important reduction, and in 2018 we arrived to a plateau with the use of blood products of 1,225 units of blood and only 490 units of plasma. And what the activity generated until end of 2021, only in Jehovah's Witness population, we see more than 6,000 hospitalization patients with almost 23,000 of hospital stay more than 4,000 scheduled surgical procedures, more than 600 urgent surgical procedures with a surgical mortality of 0. And we perform 479 births between cesareans and normal parts. Okay, and we can see here the evolution of the surgical activity that remains a normal activity, so less 2020 by the pandemic that decreased severely our activity. As example of activity, we can show the activity in cardiac surgery in our hospital. Until 2021, we have 142 patients has been operated cardiac surgery with a low error score of 27 and very high error score of 25. This kind of procedure was isolated cardiovascular bypass, where only 54 and 24%, valvular replacement 40%, combined valvular and cardiovascular bypass is 8%, surgery over aorta and 10%, including 3 patients with a type A aortic dissection, and miscellaneous of 7%, and redo procedures 8%, and all of that with a mortality of 0. What's the message, in my opinion, to take home? It's essential to incorporate transfusion medicine as a subject in the curriculum in the university. An effective PBM program requires the involvement of all elements of a hospital. The implementation of a project similar to the PBM is an effective element, but not enough. To improve the result of the rational of blood pressures, the involvement of the state on the super state structures is essential. PBM program is a program that is made by a lot of people. In the name of all the people included in the PBM hospital, in my hospital, I want to appreciate your attention and say you thank you very much. My pleasure.
Thank you very much, Dr. Soler. That was an excellent presentation. And you definitely showed, the impact of the work that has been done over the years, and also the importance of having teamwork, right? So we'll actually go more later. And for now, we will actually go on to the third speaker for today, the symposium. This is actually, we're talking about Sherri Ozawa. And Sherri actually also is a close friend, and she is a good friend, and she has been a leader in the field of patient blood management for more than 2 decades. And her background in critical care nursing has enabled her to create one of the largest and most widely known or widely recognized multidisciplinary patient blood management program in the world. And everybody would know, right? The patient blood management and bloodless medicine program in Englewood Hospital, New Jersey. Sherri has actually lectured throughout the United States and also internationally, with particular focus on the creation and implementation of sustainable, organized patient blood management programs. And we know too that Sherri has actually published a number of numerous peer-reviewed abstracts, posters, book chapters, and also articles. And currently, also, she is working on the group, the task force on a WHO program that is on the PBM implementation, as well as she has been involved with the first US federal government grant via the Department of Defense, funding the creation of organized training program for physicians and other healthcare professionals in the field of patient blood management. And Sherri actually has received the Award of Excellence of Bloodless Medicine and Surgery Society in 2019, because she has actually done an excellent contribution to the science and practice of bloodless medicine and surgery. So yes, we would like to welcome Sherri Ozawa, and she would actually be presenting on the nurse as a bloodless medicine educator. and she will be telling us on the experience from the United States of America. Thank you.
Thank you. Is my sound okay?
Yes.
Okay, thank you, Ananthi. Thanks, everybody. Nice to see you and hear you all virtually. I'm sorry for this light across my face. I apologize for that. I can't seem to get the lights adjusted, so I will share my screen. And greetings from down under. I'm here in, as Ananthi mentioned, in Perth, Australia, working with the team on the implementation guidance for patient blood management by the World Health Organization. So you'll hear from Dr. Vernon Louw, I think, next on the program. He's, I think, a couple hotel rooms over. So exciting times in Bloodless and in patient blood management. So tonight I get to talk to you a little, oh, it's not tonight, I guess, for most of you. So today, this morning, wherever you are, I get to talk to you a little bit about the nurse as a bloodless medicine educator and some experience from the United States. I hope, again, that this is applicable to places far beyond the United States. So a few of our learning objectives to look at some of the basic principles of nursing care. I'm going to bring it back to some of the basics, but I know that we are not all nurses on this call, so some of it may be news to some of you. Talk about the nurse's role in communication, coordination, and especially education in bloodless medicine and surgery program settings, but of course we'll cross over a bit into patient blood management. Explain the participation of other nursing staff. We spend often time talking about the role of nurse leaders or coordinators, but what about other nurses who work in healthcare settings and hospitals? What is their role in bloodless medicine and surgery? And talk a bit about the concept of blood health. For those of you who are at SABM, I apologize that you'll have to hear a little bit more of that again. So I'll start with really what I think nursing really well embodies. We all in healthcare attempt to take this approach, which is the approach to patient-centered care. But I really do think this ties well to what we're going to talk about for a few minutes in the role of nurses as both educators and communicators in these settings. The Institute of Medicine, which of course is not called the Institute of Medicine anymore, but when it defined patient or better aptly termed person-centered care. And I won't read all this to you. Many of you know these points, but this type of care, and I think this is so key in bloodless medicine and surgery, respects and responds to individual patient needs, preferences, and values as we make clinical decisions, really as partners, right, with our patient. Must acknowledge patients' experiences, stories, and knowledge, provides care that focuses again and respects patients' values, preferences, and needs by engaging patients more, and requires that we as healthcare providers, not just nurses, all of us, but I think really others in healthcare can learn a lot from the foundations of nursing to fully engage patients and their families in this care process. So again, these are all very easy words to say. I don't think we would disagree with any of this, but of course, as healthcare becomes more and more complex and more stretched, especially in this era of COVID, which is not over, right? Really having patient or person-centered care can be all the more challenging. So a little bit about the background of nursing. I won't get too much into a history lesson, but I think it does inform sort of the evolution of where we've come, both in patient blood management and in bloodless medicine. This is a rating that gets done every few years. This is a couple of years old. I don't think a new one has been done. At least I haven't been able to find it. But always rates, of course, America's U.S. most trusted professions in terms of honesty and ethical standards. And you may not be surprised that nurses continue to come up on the top, along with, of course, our physician colleagues pretty close behind, Congress people and car salesmen way on the bottom. And we're not here to make fun of those folks, but nursing continues to really be more highly rated. And I would expect, although I don't think the data is out, that maybe even more true since the era of COVID. This is a very nice article from the literature that it's the Journal of Oncology Nursing from Europe, but I just really like the way that this describes nursing as the 21st century nursing is the glue that holds the patient's healthcare journey together in so many ways. And again, we're here to talk a bit about education, but I think this applies in so many ways to what nurses, particularly in bloodless and PBM programs, do. So again, a little bit of history about the beginning of nursing, and I have to move my own little Zoom screen here so that I can see my own slides. So the first history of really was recorded as nursing as we may know it today is during the height of the Roman Empire, around 300 of our common era here. And the empire was pretty progressive, right, in many ways, and sought to actually place a hospital. We know about their roads, but They also sought to place hospitals in every town, and the term nurses, or at least I guess the Latin term, was assisting in these newly created facilities, became more popularized actually via the Catholic Church in Europe during the Middle Ages. But of course, we all know the name Florence Nightingale. And preparing this talk, actually, I learned a lot about her history as well. And so, much of what she became initially famous for happened in Turkey, where she was dispatched during the Crimean War to Scutari with 38 nurses, and everything was really a mess, as it often is in war. But soldiers had all these terrible things happening, dysentery, frostbite, cholera, like the infectious disease, and just a horrendous situation. And she seems very logical to us now, but she argued for better sanitary conditions and really showed results, right? Process and implementation and results from that. With her structure, and the mortality rate in these folks went from 42.7% to 2.2%. And it's pretty careful statistics, right, for something that happened so long ago. But really it was because she was one of the early trialists and kept very, very careful records of what she was doing. So after this experience, it wasn't just, we always hear about her and I think the Crimean War. We don't really know what happened after, but she wrote these notes that impacted the health efficiency and hospital administration of the British Army. She did actually a study and created these notes, which really dramatically changed how things were done in the system. And she did these questionnaires to hospital administrators, and she analyzed the results. She produced these findings, and she really said this was an interesting quote: "Understanding statistics is to understand how the world works, is to understand the mind of God." And so really there was a huge change in the way military medicine was delivered throughout hospitals throughout Great Britain, and Parliament actually voted to continue to finance this work. So you may know these are called we call them coxcomb graphs, actually. That's not exactly the best name for them. I'm trying to get it's here. The polar is actually in the bottom, is really the accurate name for them, but she was able to use these sort of epidemiological graphs to track. So actually, that's why we do know that mortality changed. And it's really quite an interesting application, but she was really the first trialist. And she said that throughout her career, and this sort of reminded me a lot of those of us who have been at this field of bloodless and in PBM for much of our careers, she really faced resentment because she was going against the grain, regarded her as an interloper. And she herself said, "There's not an official who would not burn me like Joan of Arc if he could." She wrote, "But they know the War Office cannot turn me out because the country's with me." So, first and foremost, she really was an educator, an advocate for what was right, and a trialist, but really was the mother or grandmother or great grandmother of modern nursing. So as we continue this journey in nursing, and I promise we will tie it back to where we are with bloodless medicine and surgery and what I was asked to talk about, the role of nurses. But these early nurses, even after the time of Florence Nightingale, really never went to official nursing school. And we know what I mentioned to you, her history a bit, but during the 20th century, a formal schooling developed for nursing and included then specialization, as there is in medicine, with fields like orthopedics, peds, critical care, right, psychiatric nursing. And now nurses have moved far beyond this into advanced practice roles, business roles, administrative roles. So although nurses' role really was rooted in the vocational norms here of hold on a second. Oops, I went backwards on my slides. Of motherhood and homemaking. Really, nurses have developed this ability to be compassionate, caring, communicative, and have these highly valued skills that are critical to patient-centered care and deeply valued by patients and families. So although those are not necessarily what are highly valued, sometimes thought of as soft skills, they're critical in really patient-centered care. So these are some of the roles of nurses. This may not be their exact job title. Sometimes it is, but coordinator, communicator, leader, manager, researcher, etc. And now really in terms of roles and licenses and credentials, there are expanded roles of nurses as clinical specialists, practitioners, et cetera, and these many more advanced practice roles. So I talk a bit about, changing the image. And I think that we in bloodless medicine and patient blood management have helped to move this image along in our roles as leaders in the field. But this was kind of our traditional, right, image of nursing, wiping the brow of the surgeon when he was working so hard, always a he, right, being there behind and supporting. But really the modern role of nursing, and these again are just stock images off the internet, but I think the idea really is we don't know who in these pictures is the nurse, who's the physician, who's the administrator. Nurses' roles have expanded. And again, here in the United States, not unusual at all for nurses to be CEOs of large health systems, hospitals, with many, many types of other professionals reporting to them because of their both their education and abilities, but again, I think their training and the fundamental principles of that underlie nursing is, again, communicators and educators and collaborators really make them excellent leaders in healthcare systems. So we'll get into the education piece for the last few minutes here, but this is a really interesting study. I like this one out of the Iranian nursing literature, where it talks about nurses as facilitators to professional communication. It was actually a qualitative approach to this, but described nurses as the mediators of communication, as the educators. This is a slow building slide, sorry. At the core of communication, as the mediators of patient and manager communication, patient-physician communication, executor, though, of other people's duties. And it also examined this concept of the unfair workload, increased moral distress, and high levels of unkindness, really that nurses still experience in all parts of the world. So nurses really are the hub of communication, relaying and interpreting information between physicians, colleagues, caregivers, families, patients. And I do like the sentence, the ability to establish effective communication in nursing is imperative, providing the best care. So it seems obvious, seems easy. It really is sometimes more challenging than we think. So what all that background of what nursing, where it came from, where it is and where it's going, how does that apply to what we're here talking today in terms of bloodless medicine and surgery? And I am, as some of our other speakers have, expanding into patient blood management. And so you've seen this diagram probably before, where these are two obviously related fields, but much of this has overlapping principle, really almost everything, again, voluntarily and with permission stolen from Steve Frank from his slides. But I did add a little bit of content here because, again, outside of the overlapping in this Venn diagram, there are some elements that don't exist in the other, right? So specific, and this is where we're going to spend our time talking today about, in bloodless medicine and surgery, specific education and documentation and other things that are specific for our patients for whom blood is not an option, right? And then on the other side, outside of that overlap, for some patients, blood is an option and they indeed may receive blood as part of their care clinically, but much of the rest of what we're talking about in both PBM and bloodless are overlapping. But specifically, what is the nurse's role in this? So we're going to talk and divide this up a little bit. You know, there are, again, nurses who are dedicated bloodless or PBM leaders. You see some of them, some of them are on the call right now. In the picture on the left from a pre-COVID SABA meeting, some of my friends and colleagues who are nurse leaders, specifically in PBM. But we'll speak a couple minutes also about the role of other nurses in clinical settings in PBM or bloodless programs, even if they're not necessarily leading programs. So we're going to see how both of those work. So how about the clinical? And it may not be called that everywhere, but maybe let's call it the bedside nurse in bloodless medicine and surgery programs, even if they're not in leadership positions, offering compassion and support, part of all nursing roles, but especially in bloodless medicine and surgery settings, these can be really emotionally, socially, and ethically challenging. And these patients, like all patients, may face things like fear and pain, but particularly in bloodless patients, they may be further distant than other patients from friends and relatives. There may be some lack of agreement amongst family members about their position on blood transfusion. And again, this population often has had previous difficult experiences with the healthcare setting. So from every level, but especially from that bedside nurse, these patients may require and deserve an extra level of care, compassion, and support. So a little bit about the education piece, again, because that's what I was asked to talk about today. So I like to bring this concept of health literacy. You've probably heard that term as common now, I guess, in the United States anyway, as something that's very important, right, for all patients, all the population to have improved health literacy. So certainly all patients should have opportunity to improve their health literacy, but there are some specifics to bloodless patients in which they really do require more and can be helped to achieve a higher level of health literacy. Things like blood component derived therapies, what some would call blood fractions, right? Or devices or techniques that use the patient's own blood. So their literacy in those areas can be, and we might argue should be higher, perhaps, if we can help them achieve that. Than other patients, but also for those nurses and some of my colleagues here on these leadership roles in PBM and bloodless settings, really helping be part of these multidisciplinary, care teams, and do education on a continuous basis with the public, the community, other nurses, physicians, other provider colleagues, and staff members. And there are people on this call today who are exemplary and have been doing this in an amazing way for years. So if you are out there and you need some help to understand how you can either work with your nurse colleagues to optimize their communication and coordination skills to help in your PBM or bloodless programs, or you yourself need help, there's a plethora of people who are anxious to help you just on this call alone. So, and again, aside from the normal, I think, and even extra health literacy concerns, in bloodless medicine and surgery programs, patients need some additional education and deserve it. And there are often mechanisms in place here in US settings, and I know in other countries as well, about education related to patients' rights and responsibilities, as concept of what we like to say in bloodless medicine and in PBM, informed choice as a better term than informed consent, much more accurate. And again, education related to specific documentation, specific for bloodless patients. We know that documentation is an important issue to make their wishes known beyond just blood or no blood, right? We get into more nuances of different therapies that may or may not be acceptable to these patients. So that education piece is tremendous, really crosses over, into education and advocacy, I would say. So again, back to the bedside a little bit. What is the call to action for nurses, not just in leadership positions, as being at the bedside and taking care of the body's liquid organ? My anemia word was black, I'm sorry, but assessment, I won't read all this to you, but those on the call are familiar with these concepts of nurses assessing and inquiring and monitoring. Nurses really are, the bedside nurse are really in the best position to monitor how patients are or are not tolerating anemia, looking for any evidence of bleeding, right? Inquiring to make sure we are doing the right thing for those patients. And what we will call competing strategies. You like to use the alternative word, right? Competing strategies to allogeneic blood transfusion, but really more important, focused on that patient's own blood, and then monitoring and documenting, right? What happened as we treated that patient? Did the patient have the expected response or adverse reactions? Nurses really, again, can advocate for those patients and keeping their own blood healthy, right? And that's what we're talking about. And so how do nurses impact these clinical decisions? And I won't read all this to you. You can have these slides anyway, but, vigilant observation and this proactive care. Nurses are leaders in patient care and safety and are empowered to be vigilant. They can have a large role in monitoring, of course, patients' signs and symptoms and lab work on iatrogenic blood loss. And they are able to impact many aspects of what happens in a hospital. Again, if you go back to that earlier slide about the glue that keeps the whole healthcare system together, they're leaders and innovators in change management, solution finding, patient advocacy, education, and again, leading to better outcomes. So you probably have seen this before. We did this a few years ago. I won't show you this whole thing, but we did survey about 100 institutions that reported patient blood management and bloodless medicine and surgery programs via an online tool. And I'll just point out that at that time, when we asked about oversight of the program, it was about 50% or more had oversight. So these are these leadership roles. I suspect this may be even a little higher now if we were to do this again, but nurses are in certainly management and leadership roles. And it's exactly what we like to see for successful patient blood management and bloodless surgery programs here in Australia, as we're discussing this World Health Organization implementation guide. This has been a big topic of conversation as to really what constitutes success and likelihood of sustainability to a PBM program or bloodless program. And it really is, this group feels anyway, off the record, that it is in large part the role or the existence of a dedicated nurse and nurses to keep the whole thing going. So to finish up, some of you saw this at SABM, but I think this is where we have migrated to in terms of how we see what we're doing. For years, right, we talked about the disorder of bleeding and anemia, and the default treatment became blood transfusion, and bloodless medicine, as we had in the title of this conference, really became a game changer when this was not an option, as they are in bloodless centers. We really had to restore the state of equilibrium. And what really happened to that is these modalities came into play. This is pulled out of some old bloodless in medicine and surgery brochures. Many of us still have them in our programs. We may have updated some of this terminology, but these things all came together really. And this is a lot of where the education lies, right, for nurses and others and programs helping patients understand and avail themselves of this. These things all really came together to really turn into what we now call patient blood management. Of course, bloodless is, again, the cradle of that, and still at the heart of much of this is our updated definition. You see on the side, you've all heard that as that patient-centered again, and that's where we started this talk, and nurses really exemplifying that concept of person-centered and patient-centered care, but pointing again to that the patient's own blood as the most precious resource, this concept of blood as the body's liquid organ and one to be protected. And really this concept of blood health, which I think fits well in line with, again, the principles and background of nursing as a profession, really for all of us, focusing on the patient's own blood health maintenance, and really where we now are not spending our time looking and worrying about transfusion or no transfusion, discussing that, especially in the bloodless setting, but we really want to spend our time paying attention to the patient's own blood health, maximizing that and keeping that as healthy as it can be in the patient's own veins. And if you're not aware, we are designating February 13th as World Anemia Awareness Day. More to come on that. Hoping to work with multiple other societies, both medical and other type of organizations around the world to help bring awareness to this, which again is about the patient's own blood. And that's it. So thank you. Congratulations on a great meeting to the planning committee, and nice to see so many of you here. And I guess, are we taking questions, or Ananthi, you will tell me what to do next. Thank you, everybody.
Thank you, Sherri. Yes, I love telling you.
Okay, thank you, Laura.
No,
You.
fantastic presentation, of course, as always. So we'll go into the discussion and question and answer portion of this session. We only have a couple of minutes, though, because the session just went over just a little bit. So I'm just going to ask a couple of questions here, and if the panelists and various ones can look at the questions that are in the question and answer and also in the chat and answer those questions for ones, that would be great. The first one is a question related to cell salvage. So for any of the panelists that would like to answer this question, the first one there in the question and answer section, it says, as we know in Malaysia, centrifugal type cell salvage systems are currently being used in several healthcare facilities. However, it's mostly limited to cardiac surgery due to several reasons: costs, training, higher rate of bleeding, etc. I would like to get an opinion from you on the feasibility of introducing simpler cell salvage systems that are not as limiting. Does anyone want to answer that question? And Jameela, if you can see it, maybe Dr. Auerbach or Dr. who else would like to answer that?
Thank you for the question of cell salvage. Sorry. My internet is regarding the feasibility of using cell salvage. I know it's very expensive. Can I answer that? Sorry, I think my internet is a bit slow. Yeah,
that's okay.
Yeah.
You're good. You're good. Thank you.
Regarding the feasibility of using cell salvage, I know that it is quite costly. Yeah, but I hope that through programs initiated, and getting the Ministry of Health involved. I mean, in Malaysia, we could actually subsidize that partly. You know, we can find a way. Yeah, I know it's very expensive, and it's only, and usually cardiothoracic surgeons use it, but we should actually, push for actually some subsidized for the Ministry of Health subsidized cost. We could put that in our program. I'm not sure how the other countries would go about it. think that would be the way forward.
Dr. Soler, any thoughts or comments on that, or we can go on to the next one? Are you going to comment, Dr. Soler? If you are, you're muted.
Okay, now, okay. I think the blood recovery is a good solution for the bleeding patient. And really the cell saver is a good solution. But I think that it's more for the safety of the surgeon. There's one I want to explain exactly that the bleeding patient doesn't die by anemia. The bleeding patient dies by hypovolemia. And it's very important in the bleeding patient that his volemia remains stable during all the process. And the substitution of the volemia not necessarily must be made by blood, could be made by colloids or crystalloids equally. It's important to know that every blood unit that it's in the hospital put in a a blood unit has not level of 2,3 dpg. Anyone, and 2,3 dpg is very neat to transport oxygen to the patient. And we transfuse unit blood with the patient. During the next 6 or 8 hours, this amount of blood does have no 2,3 dpg and need to stay 8 hours to remain a normal level of 2,3 dpg. And at this moment, the blood is useful and the blood serves as his utility at this transport of oxygen. For that, for me, it's very important to know that the patient is in a severe anemia or he's bleeding. It's very important for the physician to recover his the volemia of the patient, more important than run to search for the blood unit. Okay. For other hand, it's true that for example, in the obstetric patient, there are a lot of experience that they use the cell saver in the patient had this bleeding in a C-section or in a normal delivery. But it's not the apparatus that save life, it's the knowledge of the physician, it's the strong of the physician to know exactly what to have in every moment to treat the patient that is in a severe or a critical condition. Okay.
All right, thank you. Thank you, Dr. Soler. So I guess we're going to take a couple more questions. So to any of the panelists that were doing presentations today, what do you have to say to healthcare personnel who get angry when a Jehovah's Witness patient or any other person refuses a blood transfusion? How can this attitude be corrected? Any, Dr. Jameela, Dr. Soler?
I would say through education, through education and getting more knowledge on PBM and the ethics behind it.
Mm-hmm.
I would think that we should actually listen to patients' voices, and accept their choice.
And I think, Dr. Jameela, you said that you've educated really often within your program. Did your education include attitudes related, it's that culture change. So did that include attitudes of different ones?
It did not include that, Yeah. It did not include that,
Oh,
okay. We should think about that, We should think about doing that. But we do have medical ethics, in our talks,
Okay.
That.
So Laura, I could comment on that maybe too, if you'd like. So, I think I didn't see the question and I'm not critiquing the question, but I think words do matter. So, and again, it is still, you've heard probably many of us say before, right? Even the use of that term refuse immediately, right, sets up a confrontational stance. So certainly many of our colleagues might use that word refuse, but decline, right? That's what we say. Patients do, they decline therapies. Otherwise, the language matters. But again, inherent to the concept of medical ethics is that the values and preferences of our patients may not match ours. And that may be about certainly blood transfusion, but about a million other things too, right? And because of the sort of historic overlay of maybe the religious context, this has taken on, for whatever reason, additional, emotional energy from some of our colleagues. And there's no perfect solution. But as we've said in Bloodless for all these years, slow, gentle pressure over time is effective both clinically and ethically. So, and I think the point is not to let those little moments pass and not to react in kind, right? Reacting in anger doesn't help the situation, but gently and slowly correcting those moments as we see them and those statements as we see them come up, and being brave, right? Patients who need and want bloodless care don't need to apologize, right? Patients have values and preferences, and we say that those are at the center of what we do. So that should not make us angry. It may have its challenges, and it may require us to, think a little bit differently. But we want to constantly, where we can, again, professionally and collegially, readjust our colleagues consistently.
And thank you, Sherri. That was exactly how the question was actually worded. So perfect. Thank you. So I think Dr. Auerbach, this is for you. What are the causatives of iron deficiency anemia? Because pregnant women do take supplements rich in iron and folate to boost their hemoglobin levels alongside diets that are also rich in those nutrients, but we still record the prevalence of anemia in pregnancy and in healthy clients as well.
The amount of iron in prenatal vitamins is as close to negligible as it could be. It borders on worthless. The diet is not going to overcome the needs of the developing fetus and placenta. All women should be screened for iron deficiency at presentation, and if the levels are low in the first trimester, it is not prudent to expect them to correct it with diet unless they are incredible fans of chicken liver, which is extremely high in iron. I normally supplement them with ferrous sulfate or another form of oral iron every other day. When we get to week 14, horsing around makes no sense. Intravenous iron should be given as a total dose infusion. The fetus needs it. Iron deficiency at any trimester is associated with a statistically significant increment in autism spectrum disorders. So waiting or rationalizing makes no sense.
Thank you. Let's see. Maybe we need to advocate for transfusion education during medical school that is not less in-depth and amount of pharmacology education in both areas. The prescriber must be aware of the details of indications and risks of what they are prescribing. And Dr. Soler, I think you alluded to this education. Did you have the master class? Maybe you could speak to that question. And you're muted, Dr. Soler.
Okay. Well, transfusion is the most usual procedure in all the medical activity, and this performed for the most number of different specialties: pediatrics, obstetrics, surgeons, traumatologists, orthopedics, cardiologists, all kinds of specialists make transfusion. And they make transfusion with the low of knowledge about it. For me, it's very, very important that the knowledge starts at the university. Very, very important. I think that it's emergent that the medical transfusion will be its position, its situation in the curricula on the all universities, because, as I say, is the most usual medical procedure. I say that almost 6% of all patients that are entering in a hospital will receive one kind or another of the blood transfusion. And that implies the importance, the necessity of the need that all the physician receives a formation in medical transfusion during his formation at the university. Okay.
All right. Perfect. Thank you. Thank you, everyone. I'm going to turn this back over to Ananthe to conclude this session. And thank you, everyone.
Thank you, Ilora. You did a really good job actually in handling the Q&A session. And yeah, from what I understand, since we do have a little, only perhaps one speaker for the industry session, perhaps we can have a little bit more time just for any additional comments. And we have a few panelists here. So I would probably invite Dr. Samuel Manchuso. Perhaps if you have any comment, please feel free.
Sure. Yeah. Thank you for the invitation. I was positively astonished by the comment about words matters by Sherri Ozawa, and then her answer was amazing about the fact that the words that we use have a meaning, and they have also an impact in communication on our sensitiveness and the sensitiveness of our patients too. So the idea of refusing and declining is different. So we express that we do not want a treatment, for example, and our patient doesn't want a treatment, but refusing something more violent, of course. So it is a matter of education of our colleagues, of course, but not only medical education, it's just being polite also sometimes. And so being tolerant about all the different kind of populations we have nowadays. And on the side of medical education, of course, we have to answer with data, of course, because if we have to express an opinion, we can express the opinion of our own religious background, maybe our sensitiveness about our spirituality. But if we are talking as doctors, we have to answer with data and with literature. So we are not expressing opinionism in our hospitals, but of course we have to answer with data. And the outcomes of Jehovah's Witnesses are equal or better according to literature in all the settings we know. So this is the answer about our colleagues getting angry. And sometimes they get angry and they're not reasonable. So in that case, we don't have to waste our time sometimes.
Thank you very much for your points. And it's true, actually, communication is very important. And the idea in a way is like we want to build bridges and not walls. Yeah, because you can accomplish a lot if you really know how to communicate well. And it's true. Yeah. Perhaps also in a way that we can teach our patients to actually communicate their wishes in a positive manner, as what was mentioned in yesterday's talk. Yeah, it's good. Thank you, Dr. Manchuso. And yes, so we have another panelist over here. Perhaps Abigail Ibarra, would you like to say anything?
She's speechless.
Thank you very much for the invite. I appreciate. I want to say today's presentation is very marvelous, so amazing. We want to say thank you to all the presenters. Sherri, actually, nurses are all around and they are glued team, as she rightly said. Nobody can do without the nurse in the health sector, and that's why the multidisciplinary team in which we are, nurses are very, very important. We are educators to our patients, not just to our colleagues, but to every team member that we work alongside with. And I appreciate all the presenters. I will look more to others who will be presenting theirs later and tomorrow. Thank you.
Thank you very much, Abigail. And so that's a nice roundup. Yeah, because like I say, nurses are actually like glue, right? So bring the team together. And so again, bloodless medicine and surgery is multidisciplinary, and yeah, it covers everyone and working together. So that was a good discussion. And perhaps now we can actually move on to the next symposium session. And thank you very much, everyone, for being a part of this first part. And I would like to introduce the next moderator. Our moderators are Dr. Louw and also Dr. Louw, and they will be introducing the next session. Thank you, everyone.
Thank you very much for a very amazing session. I thoroughly enjoyed every bit of it. And once again, I want to greet our participants from around the world. Good morning, good afternoon, good evening, depending on where you're joining from. I'm Dr. Louw, consultant anesthesiologist at the University of Calabar Teaching Hospital. I'm an associate professor of anesthesia with the University of Calabar here in Nigeria. And it is my pleasure to welcome you to this session on bloodless surgical techniques. My co-moderator is Dr. Louw, a professor of pediatric hematology and director of pediatric sickle cell program at the University of Illinois, Chicago, United States of America. I would just invite Professor Louw, please.
Thank you very much, Dr. Louw. Good morning from Chicago. I'm very pleased to be part of this session, and I learned a lot in the previous portion here about how to implement things, and we can try to put some of that in place here. So many things online makes it possible for us to just pull it directly. In this session, we will have 3 speakers on the symposium: a hematologist, an anesthesiologist, and an interventional radiologist. The first topic will be perioperative anemia diagnosis, prevention, and treatment without blood transfusion by Professor Vernon Louw. Dr. Louw is a very esteemed, well-respected hematologist, chair and head of the Division of Clinical Hematology, Department of Medicine, University of Cape Town. He was previously professor and head of the Department of Internal Medicine and Faculty of Health Sciences at the University of Free State in South Africa. His research focuses on patient blood management, transfusion medicine education, hematologic malignancies, and HIV-related hematological disease. Dr. Louw has authored or co-authored over 100 papers and over 300 posters and oral presentations at meetings local and national. He's a member of professional societies that include American Society of Hematology, the AABB, and the ISBT. He serves on the WHO Strategic Committee for Patient Blood Management, the Global Transfusion Forum Steering Committee and Education Subcommittee, the Global Standards Committee for Transfusion Medicine, and International Collaborative for Transfusion Medicine Guidelines. Heavy hitter, Dr. Louw. Welcome.
Thanks so much, Professor Louw, for that kind introduction, and thank you to the organizers for inviting me. It's really a pleasure and a privilege to be here. And it was nice to just listen to Sherri speak. We're both here at the same meeting in Perth in Australia, where we're trying to figure out the way forward with patient blood management, as she mentioned. So so really great to be here. And my topic for this evening is perioperative anemia prevention. If I say this evening, it's evening here. I think it's lunchtime, perhaps where you are, and good morning for some others. I just want to quickly recognize Dr. Michael Auerbach that I see on the panel, someone from whom I've personally learned a lot and for whom I've got a lot of respect. And I just want to say that it's a big privilege to be in the same group where he is present. So these are just my disclosures, both in terms of support for some things and in academic associations. I don't think there's any conflicts of interest specifically related to this talk this evening. So just to start off, this dog's name is anemia. And anemia, unfortunately, is an abandoned dog, neglected, very lonely. And here he is with his friends, tiredness, forgetfulness, irritability, and cravings. And fortunately, there's someone up the hill, a very kind lady who sent her high quality milk that's been tested for all kinds of infections and filtered and made sure to be very safe. And she sent someone to give anemia a little bit of milk to drink. And anemia lived happily ever after. True or false? Well, obviously, anemia needs a lot more than a little bit of supplementation as a gift from someone now and again. Dogs need a lot of good things to be able to survive, not just food. And unfortunately, anemia is often also managed like an abandoned dog in medicine. Tonight, I want to speak a little bit about this. Problem is, with anemia, we don't prevent it, we don't diagnose it properly, we don't look for a cause, we don't treat it properly. It is become so common that it's almost forgotten. And I think this is exactly one of the problems we're trying to address with patient blood management. So what is it? You might have seen that there's a recent publication with a global proper definition of patient blood management. It's a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. So where blood transfusion and blood safety often deals with the donor's blood, here we are interested in a patient with a built-in blood factory. And the concept is thus not centered on a specific pathology or procedure, like transfusion medicine or a blood transfusion, not centered on a specific discipline. It is aimed at managing the resource of the patient's own blood, the factory alive and well inside the patient. And we're shifting attention away from the blood component to the patient. And it's based on these three pillars of optimizing red cell mass, minimizing blood loss and bleeding, and harnessing and optimizing the physiological reserve and capacity of the patient to manage and to tolerate anemia. Now, anemia is the most common problem on earth, at least the important one. Some people might say, no, there's more people with dental problems. Well, as a medical doctor, I can't do much about that, and I'm sure there are many people that's looking after that. But generally speaking, dental problems is not a fatal issue. More than half of cases of anemia is due to a simple, solvable problem, iron deficiency. And just as an example, in South Africa, the region where I come from, you can see here, this was in, look at the title, the iron status of a healthy South African population. 39.8% of participants were iron deficient, and in Black Africans, 56, in females and Black Africans, 56 and 50% respectively. I do not call that healthy. I think one could retitle this as the iron status of an apparently healthy South African population, because every person in this study is at risk of iron deficiency anemia. Who is most affected? You can see here on the far right, those of us living in sub-Saharan Africa, which I think is a large group of the people present today. This is the place by far that suffers the greatest burden, but it's not only us, it's all over the world, and not even the high-income countries of the West have been spared. Another example from my country, preoperative anemia and clinical outcomes. This was a nationwide study looking at more than 3,000 patients. What they found was that at time of arrival at the hospital for elective surgery, not for acute or trauma or nothing like that, elective surgery, 47.8% of patients were anemic. And this was associated with an increased risk of mortality with an odds ratio of 1.7, critical care admission odds ratio 1.5, and longer hospital stays. Now, the thing is, in the surgical population, iron deficiency, whether absolute or functional, is by far the most common problem. You do see some folate and B12 deficiency and renal failure as causes, not insignificant and needs to be treated. But iron deficiency, 84%, and you can see here 6% absolute, 94% iron restriction. And that needs to be recognized because that is treated differently. And I'll come back to that. So let's imagine a perfect world. In a perfect world, you, your family member, or whichever person or patient that comes to the hospital who comes to the hospital for elective surgery would come with a preoperative hemoglobin of at least 13, which is normal. Intraoperatively, it will remain that way, and postoperatively, it wouldn't change. Why? Because in a perfect world, someone would have optimized the hemoglobin before the operation. During the operation, no blood would be lost, or if any blood is lost, all blood would be salvaged, and the same in the postoperative period. In the real world, however, preoperative hemoglobin, as we saw, is suboptimal half the time. Intraoperatively, we lose blood, and postoperatively, it is even lower. And the traditional response to this has been to, whenever the HP is low, in any one of these intra, and post-op situations, is to transfuse. And for that reason, it has been estimated that surgeons use about 50% of the world's blood supply. And you see, I've cited Dr. Auerbach there. Now, we can think of transfusion as an innocent bystander where we're trying to attempt to do something good. And yes, I do believe that we can sometimes do something good, but transfusion, together with anemia and blood loss and bleeding, are all independent risk factors for increasing adverse outcomes in patients. So all have risks for patients having poorer outcomes. Not to speak of the money issues, the economic issues that are so important everywhere, but in particular in our part of the world. And if you take crude oil, that yesterday was $88 per barrel, that's about 1,600 South African rands. If we translated that to the cost of blood, and you take the similar amount of blood, that would cost you just over $50,000 per barrel for the same number of liters. But if you take crude oil and you fractionate it, you can increase the value of oil from $88 to $440 per barrel. But if you fractionate blood, the value goes up to $182,000. I say value, but it's actually cost, because that cost comes back to the taxpayer, to the government, and is, of course, very expensive. So every cent saved on blood is cents saved that can be used elsewhere. Now, the response to this traditionally has been blood conservation. And I think that was obviously not bad, because people try to find ways to use blood more optimally, to not use it inappropriately, and that's a very logical response. And for that reason, we had all these different studies that showed that lower hemoglobin thresholds were at least as good as higher thresholds in very many different situations. As you can see here, I call these the 7x7s, 7 areas in common areas in medicine where we know that the hemoglobin cutoff of 7 is at least as good as a higher cutoff of, say, 9 or so. And the same has been done for cardiac surgery, stable cardiovascular disease, etc. The reality is we are now in an era where we've taken a step further back. And what patient blood management is trying to do is to say, how can we get to a place where we don't even have to ask the question of cutoffs? We want to not even get the patient that close to the edge of the cliff. So how can we do everything in our ability to not even get the patient to a decision-making point for blood transfusion? And I think this is really, really critically important. And this is where the 3-pillar model for patient blood management comes from, based on this idea that our own blood is still the best thing to have in our veins. And the way I see it, if I put it for myself in common, easy to understand terms, the red pillar, optimizing erythropoiesis, means let's maximize the resource we have. Minimizing blood bleeding is about keeping what you have, and harnessing and optimizing the physiological tolerance of anemia is let's make the best of what we have, even if we might not have a normal amount. And on that basis, a range of elements have been designed for each of these pillars that we can use to minimize perioperative anemia. And I'm not going to speak about each one of these, of course, and I see there's some great talks coming up that will deal with many of these. I'm going to focus just on perhaps 1 or 2 major elements. But I think the important thing to recognize is patient blood management is a team sport. It is not a one-man thing or a one-woman thing. It is a team sport. There are many different elements that I, as a hematologist, cannot do, that surgeons can do, or anesthetists, or other people, but we must form teams that together can develop programs that incorporate all of these. Now, mapping the landscape, what is going on around the world? First thing to recognize is that preoperative anemia is not limited to one type of surgery. It's everywhere across the board. Every surgery you can think of, you will see the problem. It's common preoperatively, but it is very common post-operatively. Up to 90% of patients have post-operative anemia, which is really, really high and need to be addressed. If we look at the association between preoperative anemia and mortality, this is a large meta-analysis published in the British Journal of Surgery. Almost 1 million patients, 40% or 39% were anemic. And this anemia was associated with a significant increase in perioperative mortality, acute kidney injury, infections, stroke in cardiac surgery, and the need for red cell transfusion. It is also recognized, there's another study, that there's a dose-dependent relationship between transfusion, red cell transfusion, and mortality, infection, pneumonia, and sepsis. And here you can see the differences between just 1 and 2 units, statistically significant difference in terms of negative outcomes. This is just another slide that basically illustrates the same, but for more units of blood. Now, many of you will be aware of the large, almost 700,000 patient study in Western Australia, where we are right now. And I've had the privilege to meet many of the people on this list of authors who have done this great work to show that during a period where the population grew, they were not only through patient blood management, they were not only able to decrease the number of units of red cells delivered and transfused from 31 per 1,000 to about 19 per 1,000 population. The project also showed that there's a statistically significant decrease, thanks to the program, in in-hospital mortality, infections, stroke, heart attacks, length of stay, etc., plus an unbelievable cost saving of 18.5 million Australian dollars just in terms of blood acquisition costs, and 80 to 100 million in other costs. So obviously, there's no doubt that patient blood management falls in this ideal quadrant of low cost, better outcome initiative, and you can't have anything better than that. There's not much in medicine that I know of where you are going to save money while getting better outcomes. So practically, where do we start and how do we deal with this? So, and I think this is what the Bloodless Medicine Society is doing a lot for, is education and awareness. Everyone should be taught, from the person on the street who needs to understand the need for iron, good diets, supplementation during pregnancy, and so on and so on. We need to optimize iron and hemoglobin in mums and babies. If you, a family member, a friend, anybody you know, go for surgery, speak to them, tell them, optimize preoperative iron, anemia. Doctors should get involved in minimizing perioperative blood loss in every way possible. If there is an anemia, if there is an iron deficiency, you have to find the cause and treat. It's not enough to just say, oh, I'm iron deficient, give me some supplements. I recently diagnosed colon cancer in a 28-year-old triathlete, apparently healthy lawyer patient that came to me. She had many reasons to be iron deficient. So I could have just brushed it off, but I went through a detailed history, and she sort of tried to brush off the fact that sometimes there's a little bit of blood in her stool. I said, you're going for colonoscopy. It was an early colon cancer diagnosis. The patient has been cured, not even chemotherapy necessary. She just needed surgery. When you transfuse, we have to be accountable. Single unit transfusions as far as possible. Only transfuse if really necessary, and that is typically in a resuscitation space or in a hemodynamically unstable patient. Patient blood management doesn't have to wait for all the elements to be in place. One can start with the low-hanging fruit, start with a preoperative anemia clinic. Dr. Auerbach is the big expert in the world on that, on an iron infusion clinic. Get your patients onto IV or oral iron, whichever one is needed, and get doctors to refer patients as soon as possible. Iron is a simple, cost-effective, much cheaper than blood alternative, and can lead to better quality of life. But what do we need for the switch? First, a change of mind. And in the perioperative space, we need some time. And we need to think about the factors that affect time. So for instance, the route of administration. Oral iron is great in simple iron deficiency without inflammation, but that's a minority of surgical patients. It's not great in patients with any kind of inflammation or chronic disease or cancer or renal failure, heart failure. And this is the vast majority of surgical cases. You need to recognize this and know that oral iron is less likely to work. And it will only work if you have enough time before the surgery, and if it is well absorbed, and if the patient tolerates it or adheres to the treatment, because many patients don't like the side effects. Nobody likes the side effects of constipation or tummy pain or whatever it might be. And one has to warn the patient. If they struggle, come back, talk to us. Let's give you something else. So we have to think time. There needs to be, for elective surgery, we need a pre-op visit where we make sure that there's enough time for whatever iron we give to work to get the patient's hemoglobin optimized before the time of surgery. And as an example, if you use oral iron, depending on your starting hemoglobin on the left, I show you in the middle how many weeks on average it will take you to reach a target of 13 grams per deciliter. And this is if the iron is well absorbed and tolerated. But even then, the patient often needs to continue to take the iron for at least 3 to 6 months to optimize their iron stores post-operatively. And this is even true in the non-operative setting. So we want a patient with a tank that is full, not only full of hemoglobin, also full of iron. We don't want to wait until we get into dangerous territory and close to a place where we can really have big trouble. And heaven forbid that we let the patient ever get there, and that we do things where we could have avoided for the patient to get to this point in the first place. The higher the patient's hemoglobin, within limits, of course, but let's say the more normal the patient's hemoglobin, the more reserve they have to tolerate whatever comes their way. If something unexpected happens, there is a massive bleed, they have margin. We want margin, the same in pregnancy. So remember this, before surgery, you need enough time, but we also mustn't forget the perioperative and postoperative phases where replacement might be required. So just a few quick words that helps one understand some elements of why we use intravenous iron in some circumstances. I'm going to keep this brief. This is the duodenal enterocyte, and iron basically comes from the gut at the top through the enterocyte, enters the circulation, but you will see here that it goes through this brown circle, which is called ferroportin. And you can hear from the name, that means iron door. And this iron door is locked by a key called hepcidin or hepcidin. And when there's a lot of these keys around, all the doors will be locked and iron will not be absorbed. When hepcidin is low, the door will be open and iron absorption will be increased. So in other words, hepcidin, when it is low, the doors are open and you can treat the patient with oral iron. But in patients with chronic conditions, infection, inflammation, cancer, surgery, renal failure, hepcidin is high. And when hepcidin is high, not only will you not be able to absorb iron from the gut, you will also, and you can see wherever I've put the H's, that's hepcidin. And wherever you see those circles, that's where ferroportin, these doors are. And please notice that when hepcidin is high, you can't absorb it from the gut. You also can't get it out of the iron stores in the liver, and you can't recycle it from the storage in the bone marrow and the spleen. So the patient, this is what we say we end up with when we talk about anemia of chronic disease, also called anemia of inflammation. This is it. So oral iron treatment is unlikely to work. So you need something to bypass the ferroportin, this iron doors, because the doors are locked. So oral iron absorption is blocked, and this is where IV iron is going to work much better. Now, how does this help us understand the diagnosis? First, I keep it very simple. It doesn't matter if your hemoglobin is normal or low. If the ferritin is below 30, you treat the patient as iron deficiency. In patients with some infection or inflammation, the ferritin might be higher. Then we use the transferrin saturation. If less than 20, you treat as iron deficiency. If the ferritin is even higher, but the SAT's less than 20, you may need to add other tests. Some people would add the CRP or some other tests, reticulocyte hemoglobin content and others, to determine if the patient has anemia of chronic disease only, and or whether there's also a degree of iron deficiency. And that will help you decide. That's where your hematologist might help. Don't forget B12 and folate and other causes, of course. So, in practice, preoperatively, evaluate your pre-op anemia, ideally 6 weeks before the time, to make sure you've got enough time for diagnosis, to classify the type of iron deficiency and to treat it. And then you can still use oral iron. Then it becomes a cheap exercise. If you don't want to wait 6 weeks, you're going to need to go for intravenous iron, which will be more expensive, but usually very effective. Don't forget about optimizing coagulation. And this includes knowing that there are many drugs, not just typical anticoagulants. There are many other drugs like non-steroidal anti-inflammatories, and this whole list on the left here, as well as herbs and vitamins that you can see on the right that are very commonly used by people. They need to stop these ideally, I say ideally, 10 to 14 days before surgery, because all of these can increase bleeding risk. And I've seen it. I've seen people have brain bleeds after brain surgery when they were on high-dose omega-3, for instance. This list here you can download for free. You can just put in that Stanford University and herbs that affect bleeding, and you'll get this list online. So have a checklist. That's the nice way. Go through it with your patient. Ask them, go through this. Are you taking any of these? We can use tranexamic acid. We can have intraoperative point of care testing of coagulation that can guide us as to what is happening to the patient. Post-operatively, also, there's many benefits to managing and optimizing the post-operative anemia. And in practice, again, the problem is that post-operative anemia is not well managed with oral iron. The patient has got tissue damage after the surgery. There might be infection or inflammation that is partially treated. And the patients generally do not have great responses to oral iron. So IV iron is often the best one to use. Then when you treat, don't just treat blindly. Treat to target. Optimize the hemoglobin, optimize the iron stores. I like a ferritin above 100. That's enough for one single pregnancy. That's a good number. Ferritin times 10 tells you what your iron stores are. So a ferritin of 100 means the patient has 1,000 milligrams of iron stores, which is equivalent to the needs of a single pregnancy. So in summary, preoperatively, delay surgery if necessary. If it's elective, rather delay, get the patient optimized. You and the patient will not be sorry. Peri or post-op, oral iron is unlikely to work, use IV. In patients with inflammation, cancer, who are post-operative, with renal failure, cardiac failure, you need to use IV iron. Transfusion, as I said, should be limited to patients with severe, I actually want to say, not only symptomatic anemia, it's more like significant active bleeding or hemodynamic instability. You have to find the cause of the anemia. Don't neglect that. Don't ignore it. Gastroscopy, colonoscopy should be routine in postmenopausal women and or men. Some say all men, but at the very least, all men over 50, even if there's no history of gastrointestinal bleeding. Gynecological evaluation in females, very important. Look for heavy menstrual bleeding in young females and manage that. These are some of our partners that we work with. And with that, I want to say thank you very much. And I'm happy, probably to take questions, I guess, later. And I'll hand over back to the moderator. Thank you very much for your attention.
Thank you very much, Dr. Louw, for a very beautiful and excellently delivered lecture. I love your illustrations, particularly the abandoned dog. Not that I love dogs to be abandoned. I'm not a fan of dogs, though. But I mean, it's not just fair to abandon the dog. Anemia. Thank you very much. I will not forget that. And I'm sure many of the listeners will not. On behalf of all of us, I want to say a big thank you. Please hang on until the Q&A session. I want to use this opportunity to tell everybody to put in your questions in the Q&A, and at the appropriate time, the questions will be answered. I have the singular pleasure of presenting to you the next speaker. The next speaker is going to be talking on bloodless care in critical care medicine. Education is key for the anesthesiologist. I want to believe that we have lots of anesthesiologists here. Presenting Dr. Stephen Frank, a professor in the Department of Anesthesiology and Critical Care Medicine at the Johns Hopkins Medical Institutions. He specializes in anesthesia for vascular, thoracic, and transplant cases. Dr. Frank is the medical director of the Johns Hopkins Health System Blood Management Program. And he also directs the Center for Bloodless Medicine and Surgery, a program for patients who wish to avoid transfusion. His recent work relates to clinical studies in the area of collection and analysis of transfusion data from electronic medical databases and methods for using such data to improve practice. He is currently on the editorial board for the journals Transfusion and Anesthesia and Analgesia. He has served on the board of directors for AABB and Society for Advancement of Blood Management. He has also been chair of the Patient Blood Management Committee for the American Society of Anesthesiologists. He has been chosen as a member of the Miller Coulson Academy of Clinical Excellence and has earned the Distinguished Teaching Award from the medical students at Johns Hopkins. Dr. Frank is an outstanding member of the Bloodless Medicine and Surgery Society and received the prestigious Award of Excellence from the Society in the year 2021 for his excellent contributions to the science and practice of bloodless medicine and surgery. Please join me in welcoming Dr. Stephen Frank to present his lecture. Thank you.
Good morning. My name is Steve Frank. I'm an anesthesiologist at Johns Hopkins Hospital, and I run our hospital's bloodless medicine and surgery program for the last 10 years. And with that, we'll go ahead and get started. And here we go. I'm privileged to be a speaker at the meeting this year. The topic is bloodless care in critical care medicine and how education is key for the anesthesiologist. So here's my disclosures. I'm on PBM committees for 3 national societies. I've been on advisory boards for 3 different companies. And the history of bloodless medicine at Johns Hopkins goes deep. Back in 1977, Denton Cooley, who completed medical school and residency at Johns Hopkins Hospital, he's also known to implant the first artificial heart. But in 1977, he reported over 500 cases of cardiac surgery without blood transfusion for Jehovah's Witness patients. And back then, they were impressed that mortality was only 10.7%. Nonetheless, Denton Cooley is considered the father of bloodless medicine. And here we are 45 years later, and at our institution today, we have the Center for Bloodless Medicine and Surgery, and for about 10 years, we've been providing the best care for patients without transfusion when they are interested in that type of medical treatment. Now, what I want to emphasize is that bloodless care is not simply withholding blood. In fact, there's a lot in common with patient blood management. And bloodless medicine and surgery is designed to avoid allogeneic transfusions completely, whereas patient blood management is designed to reduce unnecessary transfusions. And they do have very much in common that we'll review during this talk, because we use the same principles to either reduce or avoid transfusions. So first, who can't be transfused? About 90% of our patients are not transfusible because of personal or religious reasons. And about 10% either have alloantibodies or no blood available, at least compatible cross-match blood available. And when you talk to the Jehovah's Witness patients, they really divide the blood components into 2 different categories. And those are the major fractions in the red portion of this diagram that they consider unacceptable, like red cells, plasma, and platelets, as well as leukocytes or whole blood. And then the minor fractions shown with the green arrows that are considered to be a personal choice. For example, albumin, cryoprecipitate, prothrombin complex concentrate. These are considered to be a personal choice, as are the blood substitutes like hemoglobin-based oxygen carriers. And in our experience, about 90% of our Jehovah's Witness patients will accept these minor fractions. So I often say that we used to think that Jehovah's Witnesses were crazy back until 1984, when that was the most dangerous year to have a transfusion, because you can see HIV in green and hepatitis C in red hit their absolute peak prevalence in the blood supply in the United States. So about 1% of the blood units in the US could transmit these life-threatening viruses. And since then, blood's gotten much safer, but you can see many other infectious disease agents have come out, such as babesiosis, the Zika virus, etc. And so now we do our best to test for these pathogens, but the risk is not zero. So in a recent review article that we published in the journal Anesthesiology, we reviewed the primary methods for avoiding transfusion when transfusion is not an option. And we like to divide the techniques into preoperative, intraoperative, and postoperative interventions. For example, preoperative anemia is a hot topic, and treating pre-op anemia is critical in patients who want to avoid transfusion. However, the intraoperative and the postoperative techniques are primarily involved with keeping the blood in the patient. In fact, 12 of the 16 methods on this table here involve keeping the blood in the patient. And this is our motto when it comes to bloodless medicine, because all the EPO and all the iron in the world can't make up for a large blood loss during surgery. So we like to stop the bleed and keep the blood in the patient. In fact, we've noticed that when surgeons focused harder on hemostasis, when they try harder, blood loss goes down. In fact, I say that blood loss is sometimes inversely proportional to how hard the surgeons try, because when they tie off small bleeders and use topical hemostatics and do meticulous surgical technique, they often lose half as much blood. So, for example, we did this complex spine fusion with multiple level of hardware placement, including a corpectomy and an interbody fusion without transfusion in a Jehovah's Witness patient. And I counted 8 different devices here that the surgeon used to keep the blood in the patient, including a patient warming device, which we'll talk about in a minute, multiple different cautery devices, and even a bone scalpel device. In fact, maintaining normothermia is critical to reduce bleeding. We've known for years that patients bleed more below a core temperature of 35 degrees centigrade. But recently, we even have good evidence that patients bleed more below 36 degrees centigrade, and that even with mild hypothermia of only 1 degree of hypothermia, blood loss increases by 16%, and this is from a meta-analysis. In fact, there was a 22% increased risk of transfusion with even 1 degree centigrade of hypothermia in this meta-analysis. So maintaining normothermia is critical in keeping the blood in the patient. Another way to keep the blood in the patient is to collect the blood patients lose during surgery into a cell salvage device like this. And we've shown that cell saver blood is not only beneficial to keeping the blood in the patient, but it's also a higher quality of blood compared to banked blood because it's only been outside the body for 2 or 3 hours, hasn't been stored in the blood bank for up to 6 weeks. like allogeneic red cells. So we've written a few review articles on cell salvage, and there are multiple devices on the market, of course. But we've also shown that when you measure 2,3-DPG levels in cell saver blood, shown in green, they were identical to fresh pre-op patient blood, shown in dark blue. However, stored blood or banked blood, even when it's stored for a week or two in the blood bank, develops a deficiency in 2,3-DPG of about 90% of the normal level. And this causes a left shift in the hemoglobin oxygen curve for banked blood. In fact, this left shift for banked blood shown here did not occur in cell saver blood. And the left shift makes it more difficult for banked blood to offload oxygen at the tissue level. However, cell saver blood was as good as fresh blood. So our paper was written up in the media about recycled blood or cell saver blood being better than donated blood or banked blood for transfusions. They said we recycle a lot of things, paper, plastic, metal, but we can also recycle and give patients back their own blood, which is a higher quality transfusion. So in the critical care unit, patients lose a lot of blood just for lab testing every day. And we took a survey in the 5 adult ICUs at Johns Hopkins Hospital on how much blood patients lose to lab testing every day. And it turns out that about 60 mLs a day are either sent to the lab or thrown in the trash as wasted discard when we clear the lines to get a clean sample. And so 60 mLs a day is just over 1% of 5-liter adult blood volume, which, by the way, 1% is how much erythropoiesis we have every day. We destroy and create about 1% of our red blood cells. So you're basically canceling out any benefits of erythropoiesis by sending this much blood to the lab. The neuro ICU has these inline devices that return the wasted discard, and they were able to cut the blood loss in half. But we've switched to smaller phlebotomy tubes throughout the hospital. We've gone to the medium-sized pediatric tubes that hold between 2 and 4 mLs. For Jehovah's Witness patients, we often use the very smallest tubes, the neonatal tubes that hold 0.5 mLs. And let me point out that 0.5 mLs is 5% of the blood, or 1/20th of the blood contained in this adult size 10 milliliter tube over here on the left. So we can dramatically reduce blood loss and keep the blood in the patient by using smaller phlebotomy tubes. Another way to keep the blood in the patient is tranexamic acid, which is an antifibrinolytic. It's been around for about 50 years. However, only in the last decade has it been used and been called a game changer in the orthopedic world to reduce bleeding and transfusions. In fact, when we started giving tranexamic acid back in 2014 for our joint replacements, we had this dramatic decrease in red cell utilization. Also, we hired new surgeons, and randomized trials came out in the New England Journal about that time showing lower hemoglobins were safe. So tranexamic acid played a major role. So another option that we sometimes use when we run out of options and patients develop severe life-threatening anemia is a hemoglobin-based oxygen carrier. And the only one that's still available for compassionate use right now is the one called Hemopure. Sanguinate didn't make it to the market, and is no longer available. Hemopure is still trying to make it to the market. It's a polymerized bovine hemoglobin molecule that carries oxygen and carbon dioxide and can be used when allogeneic blood is not an option. So pre-op anemia is really important when patients can't be transfused. So the question arises, what is an adequate preoperative hemoglobin? And the answer is it depends on the case. In fact, one project we worked on recently is to calculate the optimal preoperative target hemoglobin. And the way we've done this is to take the allowable blood loss formula that we all learned in anesthesia training, and we solved the formula algebraically for the preoperative hemoglobin, shown here on the left. And if you have an allowable blood loss or an estimated blood loss, plus an estimated blood volume, and the lowest tolerated post-op hemoglobin, you can calculate the optimal target preoperative hemoglobin. So if you use this formula that we derived to create this nomogram, I'll give you an example. If you have a patient who's 100 kilograms and you're going to lose 1 liter of blood during surgery, the preoperative hemoglobin that you need is only about 9 grams per deciliter. But if the patient's 50 kilos and scheduled to lose 1 liter of blood, they're going to need a pre-op hemoglobin of about 11 grams per deciliter. So we've used this formula and nomogram to calculate the optimal pre-op target hemoglobin that we aim for before surgery. And the way we do that is we use an erythropoietic order set that we built into the electronic medical record at Johns Hopkins that contains recommended doses of intravenous iron, erythropoietin, and also folic acid and vitamin B12. This is primarily used for inpatients. For outpatients, we tend to use a different iron compound called Infed or iron dextran. It's a low molecular weight iron dextran, and we can give an entire 1 gram dose in one single visit. So how do patients do when they don't accept transfusions? So in 2014, we had a preliminary report on clinical outcomes in our Bloodless program. And we compared the first 300 bloodless patients to a matched group of controls. And we found that with ischemic, respiratory, renal, thrombotic events, there was no difference. They did as well as patients accepting blood. There was a trend towards less hospital-acquired infections, and there was a lower mortality rate in the bloodless group, but we weren't powered to look at mortality with this small sample size. Also, we noted about a 12% decrease in cost with bloodless care compared to the matched control group. So it is, you achieve the same or better outcomes at the same or lower cost. But now, just recently, we've updated our outcomes database. We have 4 times as many cases, 4 more years of enrollment, and we've refined our methods of treatment. So just last month, in the themed issue of Anesthesia Analgesia, we had an updated report on clinical outcomes and cost for patients who decline allogeneic transfusions. And so we had 1,100 patients in the bloodless group, about 700 medical patients and 400 surgical patients. And you can see that none of the bloodless patients were transfused, and the nadir hemoglobin was about 0.5 gram lower in the bloodless group. And about 8% of the medical patients had hemoglobin nadirs less than 5, but only 1% of the surgical patients had nadir hemoglobins less than 5. So we definitely learned to keep the blood in the patient. When we looked at composite morbidity and mortality, we found the same or perhaps lower incidence of morbidity and mortality in the bloodless group. The p-values are less than 0.05 in the medical patients. So definitely a better outcome with bloodless care for the medical patients, but about the same outcome in surgical patients. When we looked at the individual morbid events for all patients, infection was the one that stands out. It's hospital-acquired infections that were lower in the bloodless group. In fact, in the medical bloodless patients, infection was about half the incidence compared to the control group who received transfusions. And there's even a mechanism to explain this, because allogeneic blood has an immunosuppressive effect called transfusion-related immune modulation. And that's probably what puts patients at more risk for infection after allogeneic transfusion. In fact, in 2014, there was a meta-analysis of liberal versus restrictive transfusion studies showing a higher incidence of healthcare-associated infection after liberal transfusion with red cells. So our findings are definitely believable and consistent with prior research. So if I'm going to summarize this talk, bloodless care is not simply withholding blood from patients. It's really about 16 different methods, about 12 of which involve keeping the blood in the patient to reduce bleeding. And also we have a major focus on treating preoperative and postoperative anemia with erythropoietic therapy. So this guy comes to our hospital twice a day to deliver blood at Johns Hopkins, and this is before blood management on the left and after patient blood management on the right. So we're definitely saving on blood products with patient blood management. And here's what it looks like for bloodless care. We definitely do more with less, and we achieve either the same or better outcomes at either the same or lower cost. And there's no doubt that bloodless medicine is a team sport. Here's our team visiting the Watchtower in New York at their new Warwick facility a few years ago. And here's our team presenting at the SABM meeting in Las Vegas just about a month ago. And we had 6 abstracts at that meeting that involved providing care without transfusions. And including the paper that I just presented from last month, we're up to 9 peer-reviewed publications in the last 9 years. So about 1 paper a year from our group on optimizing care for patients where transfusion is not an option. And with that, I'd like to thank the group for inviting me to give this talk. I'm sorry I couldn't be there live because I'm traveling to speak out of town on the day I'm scheduled. So I hope this recording will suffice, and it is truly an honor to be with you this morning. Thank you much.
Thank you so much. We appreciate Dr. Frank's presentation in recording and for the very valuable information. It's now my pleasure to introduce the third speaker. I messed up in my previous introduction. I'm sorry about that. This is Dr. Erin Suydam, who is trauma and acute care surgical critical care attending surgeon at the Allegheny Health Center Network in Pittsburgh, Pennsylvania. She's the medical director of patient blood management and bloodless medicine program at Allegheny Health Network. Dr. Suydam is assistant professor, Department of Surgery, Drexel University College of Medicine, and medical student surgical clerkship co-director. She trained in general surgery at Medical College of Georgia in Augusta, Georgia, and in surgical critical care at the University of Hawaii in Honolulu. And she's been in practice for 10 years. Welcome, and thank you for bringing your presentation.
Good morning. Let me share my screen here. How's that looking?
Looks good.
All right. Good morning. I'm going to speak a little bit about bloodless surgery techniques in trauma, particularly. I don't have any disclosures. And just a small background at Allegheny Health Network in Western Pennsylvania. We are a growing health system with multiple hospitals, including 3 trauma centers. So what I wanted to touch on today were just a little bit of overview of patient blood management principles in general and how we take those into account in trauma surgery, as well as a little bit about managing anemia. I'll try not to overlap too much with my co-speakers. And then to focus a little bit on coagulopathy in trauma and management strategies there, as well as managing hemorrhage in trauma. So as we all know, we want to focus on our patient and not the number. So we're looking at the patient's clinical symptoms and weighing every decision of transfusion with risk and benefit analysis. Obviously, honoring our bloodless medicine patients' wishes for no transfusion. But we want to focus on the patient's status with close reassessment and then address their coagulopathy to help stop any bleeding and to treat their anemia with other strategies besides blood transfusion when possible. We want to avoid iatrogenic anemia, as Dr. Frank touched on, which is a major issue in hospitalized patients, and avoid unnecessary blood draws. And when we are using blood products, we want to make sure that we're handling them appropriately and not wasting resources. And then most of our PBM efforts within our health system are targeted toward education of our fellow providers and assisting them with best practice by using our electronic medical record with best practice alerts and reminding them of transfusion triggers, and then auditing our performance and seeing where opportunities for improvement are. And obviously, our PBM program is encompassing the care of bloodless medicine patients as we go, and using the strategies we use for our bloodless patients for all of our patients to improve their outcomes. So as has been touched on in the last 2 talks, we want to make sure that we're treating anemia as an independent diagnosis and disease and not accepting it as an inevitable consequence of being in the hospital and having lab draws or having surgery. We know how common it is and how it's associated with increased perioperative morbidity and mortality. So we want to focus on treating anemia to optimize patients as outpatients prior to dire straits when they come into the hospital, whether it's for a trauma or a surgery. And we also use an iron protocol and with the additional vitamins for erythropoiesis and erythropoietin for patients who may not make enough endogenously, or for our bloodless medicine patients as well. And we do have a preoperative strategy for elective surgeries to help us optimize anemia prior to elective cases. And again, we know how important it is to eliminate unnecessary lab draws and limit iatrogenic anemia. And this is supported by the Choosing Wisely campaign, which is run through internal medicine, to try not to duplicate tests and perform tests that are unnecessary. And as Dr. Frank mentioned as well, we can use point of care labs, pediatric tubes, or low fill tubes to limit the amount of blood we're drawing. We can get a lot of information from arterial blood gases, which may be able to eliminate other labs. And we want to try to, in our critically ill patients that we're using central lines or arterial lines, return any blood draw to the patient so that we're not wasting blood. So to get into some of the trauma-specific considerations, we know that coagulopathy is a major factor in our trauma patients, and this is something that needs to be addressed in addition to hemorrhage to stop bleeding. So, you know, we've all heard of the vicious triad of acidosis, coagulopathy, and hypothermia, which is going to potentiate bleeding and make it difficult to stop. And this may be non-surgical bleeding with diffuse oozing or DIC or things that cannot be resolved with suture necessarily. So we want to be cognizant of acidosis and how common this will be in tissue injury and shock as the patient becomes hypotensive. And we know that this is exacerbated by normal saline. So we've really moved away from normal saline and really any crystallized resuscitation of patients who are bleeding, understanding that this is going to potentially exacerbate acidosis. But if crystalloid is needed, we would prefer LR to avoid hyperchloremic acidosis. And this also affects the clotting cascade, as many enzymatic reactions are pH dependent. So we want to try to keep that acid-base status within a normal range. We also know how hypothermia contributes to bleeding, both by causing platelet dysfunction, as well as also affecting enzymatic reactions in the clotting cascade. So it's important to keep our patients warm, both with active warming measures and warmed fluids. And we know that even at 33 degrees, which doesn't seem like very severe hypothermia necessarily, factor deficiency is down to about 50% of normal factor function. So we want to avoid hypothermia in our patients as well. We know that coagulopathy of trauma is its own entity, and that patients who have normal coagulopathy or normal coagulation and platelet function at baseline and may not even be on any kind of medications or supplements that could affect it, have coagulopathy and platelet dysfunction just by virtue of having a trauma or a traumatic mechanism. And we know some of why this is. As far as trauma-induced coagulopathy, we know that it dysregulates the protein C system, and that this is somewhat common. Up to a third of our injured patients will have trauma-induced coagulopathy. And these patients are shown to have higher transfusion requirements if they accept transfusion, as well as increased length of stay, ventilator days, multi-organ dysfunction, and mortality. So we want to make sure that we're looking for this in all of our patients, given how common it is, and make sure that we're addressing it. Similarly, in patients who have traumatic brain injury, up to a third will also have coagulopathy simply due to their traumatic brain injury. And platelet impairment is also extremely common, given the endothelial injury associated with traumatic injuries. And we know that almost half of patients may have this on admission, and almost all of them at some point during their hospital stay. So again, something that's very common and that we want to pay attention to and make sure we're on the lookout for to correct as possible. Additional factors that affect coagulopathy include alcohol intoxication, which can be associated with some of our traumatic patients and their mechanisms of injury, as well as dilution. We mentioned avoiding crystalloid and attempting to stop bleeding as a primary concern, as opposed to diluting the blood the patient has. And then a lot of our patients are older or have comorbidities and are on anticoagulants and antiplatelet medications. So another thing to try to address from the get-go to know if these patients need attention to those drugs and if they need reversed. And we know that liver disease affects coagulopathy, and that may be a comorbidity that your patient has. But to keep in mind that liver disease does not automatically mean that the patient is prone to bleeding, because the anticoagulant factors are also affected, and the patient's dysregulation is hard to predict based on just an INR. Other comorbidities that our patients may have that's going to affect their coagulation status include kidney disease and uremia affecting platelet function, hematologic disorders, iron deficiency, which, as we know, is extremely common. So our trauma patients are going to have that just as much as all of our other patients. Malnutrition or poor nutrition, and then critically ill patients are going to have abnormal hemostasis. So if that is something that's affected the patient recently prior to their trauma, that's something to keep in mind. And as I mentioned, if kind of bleeding progresses and patients go into DIC, that's something to watch out for with fibrinolysis and hemodilution, as we've already mentioned. So our patients who are on anticoagulants and antiplatelets, our strategies are listed here as far as reversal of these medications. And here I've listed or highlighted our treatments that are not transfusion related. So these would be applicable to all of our patients, including our bloodless patients. So our gold standard for the reversal of Coumadin is prothrombin complex concentrate, and then vitamin K. So that's our first line therapy when available. For rivaroxaban or apixaban, we use FIBA, or factor VIII inhibitor bypass activity. Prothrombin complex concentrate would also be an option. Or the antidote andexanet alpha, which we don't have available. It's somewhat prohibitively expensive, but it is on the market. We do have the antidote to dabigatran, which is the Praxbind, but in the absence of that availability, FIBA or PCC would be an option. And then for our antiplatelet drugs, we use DDAVP frequently, and I'll touch more on this in substitution for platelets to help encourage platelet binding and avoid platelet transfusion. So we know that it increases platelet adhesion with von Willebrand factor, and there's been some digging into this to look at the effectiveness of desmopressin in treatment of platelet dysfunction. And we've seen that it is quite effective, reducing the need for transfusions, reducing blood loss and the risk of reoperation for bleeding. And it has not been shown to have a significant difference in venous thromboembolic events. So this is a safe and effective strategy for platelet dysfunction, which may avoid platelet transfusions. At our institution, we've studied this particularly in traumatic brain injury patients. It's not the degree of blood loss that's concerning, obviously, in traumatic brain injury. The patient won't necessarily, lose enough blood to be hypotensive, but the concern is the morbidity and the result of their traumatic brain injury if the bleeding progresses. And so we want to arrest traumatic brain hemorrhage early. And our strategy has been to evaluate them with viscoelastic testing. And if platelet inhibition is noted, we've treated this with DDAVP quite successfully. And we noted that adding platelet transfusion did not make any difference in the amount of platelet inhibition on our viscoelastic testing. So we generally avoid platelet transfusion and treat with DDAVP. One consideration is that this can lead to hyponatremia, which obviously may be a concern in patients with brain injuries and cerebral edema. So we want to take that into account as well and be sure that we're not dropping their sodium too significantly. So as I mentioned, our strategy is to use viscoelastic testing. We have TAG at our institution, and we get this on every patient with significant hemorrhage or hypotension and traumatic brain injury, and assess the need for correction of their coagulopathy. In the setting of a patient who doesn't accept blood transfusion, we still have quite a few options. If the patient has decreased factor function, we could consider prothrombin complex concentrate or vitamin K. If the patient accepts cryoprecipitate, that may be an option if they have low fibrinogen. And again, if they have signs of platelet dysfunction, DDAVP would be our go-to in a patient who wouldn't accept transfusion. And then we also want to identify fibrinolysis or any development of DIC. And if that's happening, then we want to use tranexamic acid or TXA. Generally, we follow the crash study guidelines to treat anyone who's suspected of having massive hemorrhage with TXA up front with the loading dose. And then if they have fibrinolysis on their tag, we may give the second infusion dose. We utilize platelet mapping with our tags, which again, help us have more information about whether platelet inhibition is present. In a patient who is having an overall normal tag, which should indicate that the patient can make a normal clot, we again may give DDAVP and avoid platelet transfusion if they do have platelet dysfunction and a significant head bleed or a significant bleed that we're concerned may progress to more significant hemorrhage. Platelet mapping in TAG comes in two varieties. You get these two pathways, arachidonic acid and adenosine diphosphatase, which are two platelet activation pathways. And we can find whether the patient has an abnormality in those pathways and has some platelet dysfunction that may be improved with DDAVP. So moving on to a discussion more of hemorrhage, the most important thing about massive hemorrhage is to detect it and intervene early. So to stop bleeding, you need to recognize significant bleeding. And once that is detected, our pre-hospital staff, as I had mentioned before, is instructed to try to avoid crystalloid fluid, to avoid acidosis and factor dilution, which may both contribute to worsening coagulopathy and bleeding. We do utilize permissive hypotension in a patient with massive hemorrhage to avoid that pressure head on any clots that may be trying to form. As long as the patient is awake and talking to you, then they should be perfusing adequately and may accept a lowered blood pressure to avoid exacerbation of hemorrhage. You may have heard of the Stop the Bleed initiative, which is through the American College of Surgeons, which is educating and advocating tourniquet use when appropriate and how to treat bleeding with direct pressure or kaolin-based dressings or quick clot, any kind of hemostatic gauze that may be available. And we provide some of these supplies to the community. I know in our area, we've educated teachers, we've educated policemen, folks who work at museums or public institutions to have these materials available and to try to help stop the bleed before the patient can get medical attention. We do encourage them, obviously, to present to a trauma center as soon as possible or the nearest institution. And again, if you recognize or suspect massive hemorrhage, we give tranexamic acid loading dose pre-hospital, actually, our system utilizes. So often they've received it before they even get to us at the hospital. And then we want to promptly address any bleeding that we can surgically or with radiology. So if it's something that's amenable to interventional radiology, we want to contact them as soon as possible and get the patient to the radiology suite. Or we want to get them to the OR to stop the bleeding. Depending on the stability of the patient, laparoscopy may be an option even in trauma, which could potentially limit bleeding. But if the patient's truly hemorrhaging and hypotensive, most likely we're going to focus on damage control surgery, which is to pack or resect anything that's actively bleeding, tie off anything that's actively bleeding, and use hemostatic agents, which I'll touch on, to try to limit the bleeding and then get the patient to the ICU for stabilization and continued correction of coagulopathy to avoid a situation where you're doing sort of unnecessary bowel resections or anastomoses or work that can be done later while the patient's cold and coagulopathic in the operating room and starting to have sort of diffuse non-surgical bleeding that can't be addressed with suture and needs to be addressed with warming and correction of coagulopathy. We do have the advantage of having cell salvage immediately available, so we can use this even in emergencies and patients who come directly to the operating room after arrival. So in our spleen patients or solid organ injury patients or mesenteric bleeding patients, we do have the option of using cell salvage, which is really helpful if that's available to you. So again, as far as recognizing massive hemorrhage, we want to recognize shock. So this may be as simple as the patient being a little bit sleepy or drowsy with altered mental status. If they're cold, obviously changes in vital signs are what we usually look for, but we know that those come late. So tachycardia likely won't be evident until the patient's lost up to 1/3 of their blood volume already in class 2 shock. So ideally, we want to be hyper attuned and recognize shock before it progresses to hypotension, which is class 3 shock and up to 40% of blood volume loss. So again, recognition is key to act early. And obviously, a lot of these situations in the trauma bay are a bit chaotic. There's a lot of learners and people who are drawn to watch and see what's going on. And it can be a very full room with a lot of chatter and disorganization at times. So you want to make sure that you're very efficient, that there's a clear leader organizing the efforts and assigning tasks, and that you have a system of notifying the operating room or the interventional radiology suite to move patients very efficiently through this process and address their bleeding as quickly as possible. So we want early action. We want, again, to avoid crystalloid or hypertension, and we need to make sure that we have that coagulopathy in mind and what our efforts can be to address that. So in patients who do accept blood, these are some of the indications or things that we use to activate a massive hemorrhage protocol. Obviously, in patients who don't accept blood, these are still things that we want to be attuned to recognize massive hemorrhage. So the mechanism and severity of the injury, the patient's hemodynamics, evidence of active hemorrhage, either internally or externally. We do know, however, that a clinical assessment is a poor predictor of whether the patient's massively bleeding or not. We're not very good at just kind of guessing by the look of a patient. So we do use scores to help us identify patients who are massively hemorrhaging. Here, we particularly use the ABC score, or the assessment of blood consumption, which I'll talk about on the next slide. And then understanding the need to act early is going to decrease our mortality. And if you do transfuse, it's going to decrease the overall number of products that you need to use, and obviously the cost. So our massive hemorrhage protocol includes this ABC score, which includes tachycardia, or pulse greater than 120, systolic pressure of less than 90, a positive FAST exam. So a FAST exam is a focused assessment with sonography and trauma, or in ultrasound, which we use in the trauma bay. We look in the pericardial region for any pericardial tamponade or presumably blood in the pericardium. And then we look in the right upper quadrant between the liver and kidney, and the left upper quadrant between the spleen and kidney for any evidence of bleeding, as well as in the pelvis for any fluid outside of the bladder, which would be concerning for hemoperitoneum. So a FAST exam is a very quick and easily available tool to determine if we think the patient has internal bleeding. And then the last criteria is penetrating trauma of the chest or abdomen or pelvis, which would be more likely to cause bleeding. So if the patient has 2 or more of those 4 things, that's a positive ABC score. Additionally, if the patient has persistent hemodynamic instability, or you know that you are going to the OR or the IR suite, or you're massively transfusing the patient, those are all indications that you have a massive hemorrhage and you need to activate your protocol to address it. So again, short of blood transfusion and bloodless medicine patients, we do potentially have cryo precipitate as an option. We know that that's the most concentrated form of fibrinogen. So if the patient's fibrinogen deficient, it's the best way to correct that. Similarly, we talked about DDAVP and the usefulness to help platelets adhere and have better platelet function. And then we talked about prothrombin complex concentrate and FIBA as options in addition to vitamin K for coagulopathy or factor inhibition or factor deficiency, or dilution or consumption. Just to keep in mind, if patients have been on a lot of antibiotics, they may have a lack of vitamin K, or if they have gallbladder disease, those patients particularly may be deficient in vitamin K. And then we talked about the use of TXA, as well as cell salvage. I know we don't have available, we used to, but there are options for collecting blood from chest tubes. If your patient has a hemothorax and has a chest tube placed, there are containers that can collect that blood, and you can retransfuse that to your patient. And again, we review every massive hemorrhage protocol and every activation to have quality assessment of how we're doing and how we can improve in addressing our patients with massive hemorrhage. In the operating room, we have quite a few materials available to help with hemostasis, in addition to suture or resection or whatever procedure you're doing to resolve the bleeding. But for any residual oozing or coagulopathic bleeding, we have fibrin, we have Surgicel, we have wax, we have TXA that can be used exogenously or on the surface, as opposed to IV TXA that we give. And we have multiple hemostatic options too, as far as electrocautery, argon beam, bipolar, all of these things to try to help stop bleeding. So our goals are to be efficient in reducing blood loss and act early, and limit further functional damage, particularly an intracranial hemorrhage. We want to prevent further bleeding and further brain injury. And this will meet our SABM standard, which is to manage coagulopathy and use TXA when indicated, which is in all patients who have trauma and significant hemorrhage per the CRASH trials. And that our massive hemorrhage protocol includes guidelines for management of hypocalcemia, hypothermia, again, addressing coagulopathy and doing all the adjuncts of correcting acidosis to prevent our vicious triad or our other factors contributing to coagulopathy besides just abnormal factor function. Just had a brief sort of case scenario to try to highlight how we apply PBM to our patients. So in this example, this is a level 1 trauma patient who's a 70-year-old male who's fallen down a hill and presents with altered mental status, a scalp laceration, and he is on Coumadin. So that is identified. So when he first arrives to us, it's noted that he has altered mental status with the decreased Glasgow Coma Scale. His scalp laceration is noted. And in our workup, we find that the patient does have intracranial bleeding with a subarachnoid hemorrhage, as well as multiple fractures of upper and lower extremities. And initially, we note that he is anemic already with a hemoglobin of 10.7, and his Coumadin is working, and his INR is 3.4. So things that we want to sort of highlight and address, pre-hospital, the EMS or emergency services can address his scalp laceration, the external bleeding, with direct pressure or hemostatic gauze to make sure that we're limiting how much blood he's losing from a scalp lac. As we know, those can bleed pretty significantly because it's very well vascularized. Once the patient gets to us, we want to control that hemorrhage by repairing the laceration, or again, controlling the bleeding from any external source. And knowing that especially a femur fracture can lose a significant amount of blood in the thigh, we want to make sure that his extremities are immobilized to avoid further blood loss. For his traumatic brain injury, we're going to get our viscoelastic testing to see what we can reverse as far as any abnormalities, but we know that he's on Coumadin with elevated INR, so we would give this patient prothrombin complex concentrate to reverse his bleeding. And then we would look at our viscoelastic testing to see if he would benefit from DDABP or any other interventions to help his bleeding stop. And then with his multiple orthopedic injuries, we know that this patient is going to require multiple operations to fix these fractures with the orthopedic surgeons. So we want to make sure that we're addressing and avoiding worsened anemia from the beginning. So we'll collaborate with our orthopedic colleagues to use all the intraoperative tools that are possible to limit blood loss in the OR. But we'll also avoid making this patient's anemia worse with excessive lab draws. And we'll make sure that we start treating his anemia from the beginning to try to help him recover and to limit the degree of anemia that he may have throughout his hospital stay in his multiple ORs. So as we all know, we've learned so much from the experience of caring for bloodless patients, which can translate to our patients who do accept blood. So for all of our patients, we want to have individual patient-specific treatment plans. So again, back to the first slide, we're focusing on the patient, not the numbers or the algorithms or what we've been taught or used to our whole careers. Each patient we want to assess individually and determine the risks and benefits and how we can treat that particular patient. And we want to focus on their clinical status. If they do have hemorrhage or trauma, we want to stop the bleeding as quickly and efficiently as possible. And then we want to, in addition to avoid worsened anemia with excessive lab draws, we also want to learn to somewhat tolerate anemia if the patient's clinically well and treat their anemia to help them recover. And all of this will decrease our complication rates, our length of stays, and our cost. And we know that this is a team sport for sure. Working with our colleagues to see how we can best address any of the patient's issues to get them through as completely as and efficiently as possible. That is all I have.
Thank you very much, Dr. Suydam. Dr. Louw.
Yes, Dr. Schuur, thank you very much for a very beautiful lecture. I was trying to start my video a while ago and I was not able to. Okay, it's up now. Thank you very much. Thank you, Dr. Erin Suydam. I hope I got the pronunciation correct. Thank you for a very beautiful lecture. Thank you for teaching us once again different techniques of how to keep the blood within the patient and to treat anemia as required in the trauma patients. And I'm sure that we all thoroughly enjoyed the lecture. Thank you for your time. Once again, just like I told the others, kindly stay back. I'm sure you have a lot of questions in the Q&A so that you will address them and also contribute to other answers that will be required. So I'll move quickly to the Q&A session. We have a number of questions. I want to start with the question from, the rest of the questions will be answered in the chat. Now I have a question from Sylvie Biliu that says, discuss the utility of anti-hepcidin drugs in inflammation compared to or in addition to of intravenous iron for rapid preoperative optimization. And repeat, please, normal stroke optimal ferritin in pregnancy. And Dr. John Friedman, a professor of hematology from Canada, is one of our panelists. He's a lead of Canadian on-track program for reducing transfusions. I would kindly request Dr. John Friedman to address that question, please. Thank you. Dr. Friedman, could you please unmute and address that question?
I don't think John is on, but Michael Auerbach has his hand raised.
Hi.
Okay, go ahead, please.
Can you hear me? This is for Dr. Schuur. I forgive me, sir, but I have to disagree with you about the Wang study. It used Medicare patients, so it missed 99% of the people who got IV iron over the study period. It used specious surrogates for anaphylaxis, such as Medicare coding, which cannot possibly differentiate between minor infusion reactions and anaphylaxis. But the most damning thing about that study is that in the paper's own supplemental material online that they published as part of the JAMA study, the death rate within 24 hours of administration of the iron was an order of magnitude lower with iron dextran than with any of the other formulations, effectively negating the conclusions. I don't think the Wang study should be used as an indicator of safety because iron sucrose is definitely not safer than low molecular weight iron dextran.
Okay, thank you very much. Do we have any other responses to that? All right, so we move right down to, we have a question
Sorry,
from...
Dr. Carlo, how about,
sorry.
How about the speaker?
I'm so sorry, is that Professor Louw?
Yes, that's me. Hi.
Oh, okay, so please. Oh, please go ahead.
No, I just thought if Dr. Friedman is not in the room, I can perhaps just quickly speak to this. So the question there discussed the utility of antihepcidin drugs. I think there's a lot of studies ongoing, many in early phase. There are some studies that have received orphan drug status with the FDA. And I believe there are some interesting abstracts, well, I've seen that there are some interesting abstracts being presented at the American Society of Haematology this year, but I don't think one can say much more than that. The reality is, for me, these drugs will have to be very special and very good if they want to ask a premium over iron, because I also believe, like Dr. Auerbach, that IV iron is very safe if used correctly and in the correct circumstances according to the label. So I think the use of this is probably going to be in other areas like polycythemia vera, where we often struggle with certain problems around iron deficiency and bloodletting. The question about optimal ferritin in pregnancy, this is an area where people might differ. For me, I like the ferritin in pregnancy to be above 100. If you calculate the need for iron in pregnancy, then it's usually up to over 1260 milligrams minus the, there might be different calculations from different studies, but minus the amount saved by not menstruating. So more or less an extra gram per pregnancy, which equates to a ferritin of 100. And because there's so many negative effects of iron deficiency on the developing fetus and the neurocognitive development, I feel very strongly about optimal iron levels in pregnancy. So I'm going to maybe pause there because I see Sherri has a hand up, and maybe I'll come back later.
Thank you very much. Thank you so very much. I think if there are controversies in areas where research is ongoing, we'll gather evidence and with time probably do some systematic reviews and multiple studies to look at what the evidence is saying summarily around the world. And definitely there will always be opinions and counter opinions depending on where people lean. But it's good that we are putting this on the table for discussion. I want to thank everybody that contributed answers to that. I have a question from David Smith for Professor Louw. Thank you for a great talk and the down-to-earth illustrations. Can you give us a guesstimate of the extent to which blood transfusion could be reduced globally if the measures outlined to correct anemia were utilized consistently and aggressively?
Yeah, so there are many, many examples in the literature, but a few of them, the largest study from Western Australia, I think the reduction there was 40%. We've got a number of hospitals in South Africa now where the reduction has been around about 50%. One of my colleagues that's also involved with a meeting that we currently have here with the WHO in their hospital in South Africa, they've decreased use by 60%. And our colleague from Mexico, who's got a very large scale patient blood management program in Mexico. They've decreased use by 60%, 60, not 16. And he also presented some data from the intensive care, where since September, they've been able, in one intensive care with 42 patients, they've only needed to give 1 unit of plasma over that period, which is remarkable, with a very intensive patient blood management program. So it seems like, depending on the extent to which you roll the program out, you can do quite a lot.
Okay, thank you very much for that. I'm going to move to a question by Sylvie. Has contributed so many questions to us. She's asking how much blood is lost in priming the cell saver. I think that's what she wanted to write. Hard to convince anesthetists in a case where it is not clear how much blood will be lost. Do you have specific criteria to decide to start the cell saver? I believe this question was for Professor Frank and Steve Frank. And I don't know if somebody is willing. Okay, is Erin trying to answer the question? All right, thank you, Erin.
No problem. I'm happy to address that. So the blood that's collected by the cell saver will be spun down, and the amount of blood or red cells that you have to give back to the patient after that is hard to predict based on how much is in the tubing or how much is diluted when it's spun. But usually our criteria for elective cases, we ask surgeons to consider having the cell saver for any patient who is expected to have an estimated blood loss greater than 500 milliliters. In trauma, if the patient is going to the operating room for an exploratory laparotomy for massive hemorrhage, we would presume that the patient's lost at least 500 milliliters. So usually for a trauma XLAP, we expect that may be beneficial and we would have a significant amount of blood to give back to the patient. And then for elective cases, our guideline is if you expect an EBL of greater than 500, then cell saver should be considered. That's for all patients. You may be a little less liberal in bloodless patients to give their own patients back, depending on the surgical procedure that you're planning.
Okay, thank you very much. I know that some literature actually take it up to 1,000 mils, that it's really not economical to use a cell saver when you're expecting a blood loss less than 1,000 mils. So, I mean, 500 mils is a fair deal. And I think the question about anesthesiologists is a worldwide question. And basically, as an anesthesiologist myself, the anesthesiologist wants the patient to be safe. And I think that's what we all want. So whatever it is that is going to put the patient in danger, the anesthesiologist is going to have issues with that. So let me go to the question from David Smith for Professor Frank again. Are perfluorocarbons still under development as an alternative to hemoglobin-based oxygen carriers, or can they effectively be discounted? My screen has moved. Or can they effectively be discounted for the foreseeable future? I don't know who would like to attempt that. Professor Louw, will you like to attempt that for us? Talking about perfluorocarbons as a hemoglobin-based oxygen carrier.
Yeah, I have no personal experience with this. I believe there are still some of these products on the market. There are limited areas where they are apparently used and potentially of value, but I've got no personal experience. We don't have them in South Africa.
There are none on the market in the United States because they activate complement and in clinical trials had worse clinical outcomes.
Okay, hi Dion, I'm very happy to see you. Do you want to say a word or two on this?
I thought I'd just wave and check in. I'm very happy to see you all too. Thank you.
Oh, thank you very much. So good to see you. All right, so basically these are experimental drugs, and then we don't have a lot of information on them. So as information becomes available, I'm sure that whatever will be useful to our patients will be made available. I will go right up to a question I had skipped because it's a whole lot. Well, the rest of the interactions are thanking us, thank you. You would like to answer this question live? Okay, no. Well, okay, so I have another one here. How do you address pulmonary embolism prevention in patient blood management in PBM patients? How do you address pulmonary embolism prevention in PBM patients? I don't know if any of our panelists would like to attend to that.
I think that may be a question related to trauma patients, because we know that trauma patients are at very high risk for venous thromboembolism with their multiple injuries and immobility and fractures. So we are fairly aggressive with chemoprophylaxis, understanding that that's very unlikely to precipitate significant clinical bleeding. When the patients have solid organ injury or hemorrhage, we usually wait approximately 24 hours or until stabilization of their blood counts to start. For traumatic brain injury, our guidelines are to start chemoprophylaxis either 24 hours from injury plus a stable head CT and a significant head bleed. So those are our guidelines for VTE chemoprophylaxis. Obviously, you have to weigh the risks and benefits of a very low chance of bleeding from a prophylactic dose to the potential of the need for a therapeutic dose if they develop a significant PE. And we don't want to exacerbate bleeding, ending up having to use a lot of heparin drips on people with acute PEs. So that very, very low risk of bleeding with prophylactic dosing should really pay off.
Thank you very much. I believe we are satisfied with that answer, but let me just make a note that if you want to have further interactions, Dr. Sora, I believe, will put out the email address of the society, and you could address your questions. You could send your questions, and they will be sent appropriately to those who will be able to answer them more elaborately. Professor Sue, are you there? Okay, so I have
we
a
have
long
to leave to address an emergency, so please.
Okay. So I have
so
a long.
You now handle it.
I'm good.
Everything solo.
I'm good. So I have a long question from Danny Ash. He says education with an exclamation mark. What about informal soft education? A lot of the misconceptions and lack of awareness of the efficacy of bloodless surgery is perpetuated in people's minds by the so-called entertainment industry. TV shows featuring hospital scenes routinely teach how the first option is blood transfusion and how patients who are not given blood when they need it actually die. Such seemingly harmless entertainment has the soft power to condition and sadly even close minds, some of which end up in the healthcare world and difficult to unteach. What about a fictionalized but factual TV show, Bloodless Hospital? I think it's got a whole lot going there. So please, can we comment on this? Can we comment on this, please? Is there somebody who wants to talk on this?
I think it sounds like a great concept, something to think about.
Yes, I think so too. So I think I would like him to reach out to the society and possibly get sponsors for all kinds of things that they have passion for. So you could put a soap opera up in your national TV, and you have a bloodless hospital, and who knows, you may just be promoting the message of the Bloodless Medicine and Surgery Society. I think I'm done with the questions and answers. Dr. Sora, have I missed any question there?
I think you've done a great job. Nothing.
Okay, so we will just move right up to the industry session. And it is my pleasure to invite Dr. Ofonime Ukwe. She is a radiologist, a young radiologist in our very wonderful hospital at Calabar, the University of Calabar Teaching Hospital. Dr. Ofonime Ukwe has special interest in interventional radiology. Dr. Ukwe, please.
Thank you very much, Mom. Thank you very much, everyone. Good evening. Good to be here. Thank you for inviting me to moderate this last bit of the session today. So my name is Dr. Ofonime Ukwe, as Dr. Carlo has already introduced me. I'm a diagnostic radiologist, recently just finished my training in vascular and interventional radiology from Tanzania. And I'm currently doing my practice here in Calabar, University of Calabar Teaching Hospital here in Nigeria. Right, so I do have the singular privilege and honor of introducing our industry for this evening's industry session. And she's no other person than Dion Osewingie. I hope I got that right. She's from HemoClear. She's the Global Business Development Manager of HemoClear. And she initially joined HemoClear in 2019 as a clinical specialist responsible for the clinical trials, publications, and medical product training. In her current role as Global Business Development Manager, Dion leverages her experience from her clinical role to optimally meet surgical teams' needs in cell recovery. She's highly motivated to contribute to making the safest blood available and affordable to us. So Dion today will be speaking to us on accessible cell recovery in the obstetric setting by microfiltration technology. So let's make welcome Dion Osewingie. Welcome, Dion. You do have the floor right now. Welcome.
Thank you very much, Dr. Ukwe, and thank you very much, everyone, for having me today. It's always a great pleasure. I'll go ahead and share my screen with you. I hope you can now well see my screen. Can you?
Yes, but you need to put it on slideshow. Okay, now it's great.
Okay, thank you very much. So as Dr. Ukwe rightfully said, I'm here today representing HemoClear, and we have the ambition to boost autologous transfusion options. As I don't have to tell any of you, cell recovery is a preferred method. It is the best blood is your own blood. It's fresh, it's a perfect match, the least risks. So that's nothing new. And in line with this, you know, the medical field has fully embraced this. Policymakers are now calling, the WHO is calling for broad implementation of patient blood management, including cell recovery. And this is, I think, well rolled out in some settings. But still, generally, cell recovery is limited to those settings, the operating rooms where bleeding is a certainty, such as cardiac or orthopedic surgery, and the desire to also perform cell recovery in other settings where it's maybe bleeding's not as predictable, such as in the emergency setting or in obstetrics, but also in places where resources are limited or post-operatively. The desire to cell recover is not always translating to actually the procedure being performed. And this is due to technology not being there with the desire yet. The simple and affordable cell recovery technology hasn't been available yet worldwide to produce high quality cell recovery. The gold standard so far is the centrifugal devices, as I'm sure you all know them better than I do. And they're very effective at capturing the red cells. They're very effective at eliminating those potentially non-cellular harmful components. but there are also some downsides. It's dedicated equipment, high procurement cost, comes with expensive consumables, and you need a trained operator at all times. And another point to make is that the red cells are recuperated, but not the platelets. So in search of a simple solution, we explored cell recovery based on filtration rather than centrifugation. To support safe and effective reinfusion, you do need to obviously remove those non-cellular solutes, the microaggregates, free hemoglobin, the cellular debris, the ions, so that you don't give this back to the patient, while at the same time capturing every viable, healthy cell, the red cells, the platelets, to have an effective cell recovery. The way to do this is obviously looking at the right range of pore size. And by looking at the 1 to 10 micron range, you could effectively have cell recovery with high effectiveness that compares in quality to a centrifugal device. So based upon this concept, from this idea, the Hemoclear device was born. It's the first microfiltration solution for cell recovery, and it also includes a washing feature, by which in a 30-minute procedure driven by gravity alone, without the need for capital investment, expensive consumables, or high procurement cost, you can produce high quality platelet-rich red blood cells to give back to the same patient. What does the procedure look like? Simple and straightforward are the keywords. This is obviously a marketing representation, but it doesn't in essence take more than that. So the first step, blood collection. This is done in a sterile manner. Then after the decision's been made to give back the blood to the patient, it's transferred to the Hemoclear setup in the second picture. And by simply hanging the blood above the filtration device, it runs down on gravity. And in about 30 minutes in a 2-round filtration procedure, you produce the high quality platelet-rich red blood cells, and you can reinfuse them to the same patient in the third step. So one of the main settings where Hemoclear could boost transfusion options where they are currently still limited is the obstetric setting. And as bleeding is often unpredictable and too often still leads to a fatal end, cell recovery there is of high clinical value. However, there's of course also safety considerations that would need to be checked first to ensure that Hemoclear meets the right quality level. So this is related to the potential contamination with amniotic fluid, the potential contamination with fetal red blood cells, but also bacteria, to give you a few examples. And in order to confirm that these contaminants were reduced to a safe load, we set up a trial. I'm sure you've heard me speak about it previously also. We set up a trial in the UK with Chelsea Westminster Hospital to explore this. The trial focuses on validating that Hemoclear can also be used in cesarean sections, but also in vaginal deliveries. And put shortly, or in a nutshell, blood was collected after or in cesarean sections or after vaginal deliveries. It was analyzed for quality and then split in 2 equal volumes, one to be processed with the cell saver and one to be processed with Hemoclear, and then again analyzed to determine the performance of each of the devices. Enrolling the patients in this trial proved to be somewhat challenging because of the volume requirements. We looked out to enroll women that lost enough blood to process for the research purpose, but not too much that would make it unethical to not give back the blood as soon as possible. So in the end, some swab washing was also included in this setup. And I'm very happy, although it's preliminary it's preliminary data, I'm very happy to share some of the results with you today here. not just because I've been promising to do so for some time now, but also because with those hurdles and the research team really making an effort and achieving the right trial design and optimizing it, this brings us a little bit closer to supporting the use of microfiltration in cell recovery in the obstetric setting, and bringing it to the postpartum hemorrhage patients that could really benefit from it. That said, here's a snippet of the data. It's yet to be analyzed and completed, but this is the initial data that we got out. So when we look at amniotic fluid, which was one of the main concerns, we tried to measure that by looking at the concentration of alpha-fetoprotein as a marker for amniotic fluid. And in the first 9 participants, we saw that both Hemoclear and the Cell Saver effectively reduce the alpha-fetoprotein concentration to about 20% of what it was before processing, which is a good sign that Hemoclear, like a Cell Saver, effectively reduces the risk of amniotic fluid embolism. This is in line with the reduction of anticoagulant, in this case heparin, which also showed that starting from a higher concentration before processing, it was brought down to a comparable concentration between Hemoclear and a centrifugal device. Looking at the fetal cells and bacteria, the fetal cells, to start off with, seem to be, the concentration seemed to be higher after processing for both Hemoclear and the Cell Saver, indicating that maybe some are reduced or removed, but they're still present in the processed blood products for both devices. So if this blood were to be given back, it would obviously, as the guidelines already indicate, would have to be done with also the giving of anti-D prophylaxis. And then in line with that, and similarly, the bacterial count also seemed to be somewhat reduced for Hemoclear and somewhat elevated with the Cell Saver. Whenever given back to the patient and there's still presence of bacteria, would have to be done with antibiotics, as the medical guidelines already indicate at this point. So in summary, Hemoclear is a way to boost autologous transfusion options and make this more available also in those settings where it wasn't practical or affordable before, including the obstetric setting. Hemoclear captures not only the red cells, but also gives back the platelets, making way for the most effective cell recovery procedure. And because of the simplicity of the device, it can also extend autologous transfusion to resource-limited settings. And that is my talk for today. So thank you again very much for having me. I was very keen to share this with you and happy to receive any questions that you may have.
Thank you very much, Dion, for such an interesting presentation. Very short, but very straight to the point. And for letting us know that, yes, there is a simple and affordable method that has been provided by Hemoclear to have high quality platelet-rich red blood cells, yeah? So thank you so much. So if anyone has any questions, please put it in the Q&A. And I'm sure that Dion is very ready to take up your questions and provide answers. Are there any questions? Please type it into the Q&A. So, Dion, I think everyone is really excited. I think one question I will ask is, how affordable is this? And is available, readily available in the, yeah, I know this was like tailored towards the resource limited setting. Is it readily available beyond where you are? Is it available in the resource limited setting?
So actually, the device was designed not necessarily for the resource limited setting. It was developed and designed in the Netherlands, where we're also based. So this was our starting point, has been. It's readily available now. We're currently also bringing it to the US. And working very hard. In my view, we can't go fast enough to also bring it to every resource limited setting. In terms of affordability, that's one of the ambitions and the aims also, to make it affordable to all. So that will differ per setting, but it will definitely be more affordable than both donor blood and other devices such as a centrifugal device.
Okay, thank you very much. So hopefully once it's available in the resource limited setting, it'll be very useful and will also help reduce maternal mortality as well. Yeah, right. So there are a couple of questions Q&A. So one question is serious of the use of Hemoclear in patients in Africa. Did you get the question?
Sorry, no, the connection broke up a little bit. Do you mind repeating, please?
Right. So the question says, are there any published case reports or case series of the use of Hemoclear in patients in Africa?
At the moment, there's no case reports on patients in Africa, but this is in the works, so to say. So on the back of these initial trials, we're working very hard to start collecting also data from the African setting. So these are in the works.
Okay, right. So another person is asking, can Hemopure, I'm sure he probably meant to say Hemoclear. So can Hemoclear remove cancer cells?
The recommendation in using Hemoclear with active malignancy is to use a leukodepletion filter afterwards, because in theory it should remove, but it is still a relative contraindication to use of cell recovery. So they should be removed in theory. We don't have data on that. So according to the general guidelines, recommended to reinfuse with a reinfusion filter.
All right. So another question says, is it available in Canada? Could we have an idea of the price of the device?
The device is to be registered in Canada. So I don't have a set price or a partner there yet, but I'm happy to have a look at it if the person shares could share their details.
Okay, right. So one more question. Another person is asking, can Hemoclear be used yet in Belgium? Did you get the question? So here, Beckman.
I didn't get it completely. I think the first part was, can it be used in Belgium?
Hemoclear can be used in Belgium. Yes.
Yes, Hemoclear is available in Belgium.
Right. Okay. Okay. Oh, right. So thank you. I don't see any additional questions. Right. Okay. Okay. So I don't see any more questions. Thank you so much, Dion, for an amazing presentation. Thank you very much. Thank you so much. I think if you could probably like drop your email address or something on the chat box. So if there are any further questions, any further queries or clarifications, people can actually send you an email. So we can reach out to you via your email to probably get more clarifications. Is that okay?
Thank you very much. Will do. It was a pleasure, as always.
Thank you so much. Thank you. Thank you so much. So thank you everyone for joining on today's session. It was a very interesting day, a lot of very interesting presentations, very enlightening. Okay, Dion, if you're still there, one last question. Someone's asking if Hemoclear can be used in kids.
If Hemoclear can be used in kids, yes, there's no objection to using it in pediatrics.
Okay. Right. Okay. So that's good to know that that can be used in kids. Thank you so much. Thank you. So please put in your email address so people can reach you if they have any more questions.
Will do.
Okay. Right. Thank you. So there's a comment here. There's a case report from Suriname about post-cardiac care as an effective health saver. So I guess that's a comment or something. Do you want to say something about that?
I think it relates to the question on the case study or the case reports coming from Africa. So my answer was no. There is, however, other literature and research from other settings. So that includes Europe, the US, but also case reports from Suriname, which was commented on, I think. And I'm happy to, I will drop my contact details. I will also share that report with whoever would like to receive it.
All right. Thank you very much. That would be very amazing. All right. Thank you so much, Dion.
Thank you.
All right. So I think we can wrap up the session for today. Just by reminding us that tomorrow is the last but not the least day, and we want to thank all our very amazing speakers that were on today, and for everyone who took time out to join in the session today. It was a very interesting one, and we did learn a lot of things. And so just to remind us that tomorrow also is another day full of very interesting topics that will be discussed. So we will begin the day with a presentation by Dr. Majid Rifai. He's going to be talking about why does blood transfusion result in tissue hypoxia? And then that will be followed by the specter of immunomodulation, a case of transfusion avoidance by Dr. Neil Bloomberg. And our keynote address would be given by Carolyn Burns. She's going to be talking about PBM, state of the science or state of the art. And then we will break that session and then go into the next session. That would be the art of bloodless medicine. And the first speaker would be James Reynolds, who is the director, producer, and screenwriter of Asia Geographic Entertainment Limited in Hong Kong. He'll be talking about the making of First Do No Harm, a documentary on the history of blood transfusion. And so the day will be rounded up tomorrow with the annual general meeting of the society, and it would be chaired by no other person than the BMSS president, and then we'll be concluded with an AGM. So thank you very much, everyone, for joining in today. We look forward to seeing you tomorrow, same time, same place. See you all tomorrow. Thank you.